And for those just getting on, if you could go ahead and click on that link, you would get to the pre-test, and you'll do a demographic form first, and then it'll email you the actual pre-test. And without further ado, Lindsay, you can go ahead and launch those polls now too. So we created a few poll questions just to get a sense. We have a really eclectic group here, which is going to be so neat to see how you all are able to do contingency management in your various settings. And so we just have a couple of poll questions that are going to help us understand the various types of sites that are present today at this training. Oh, sorry. I misspoke about our poll. We are mainly seeing who's already doing contingency management at their sites in these varying settings. And then also what behavior you are reinforcing, right? So are you reinforcing drug abstinence? Are you reinforcing attendance? Or do you have a different behavior goal that you have been using already? If you're not using contingency management at your site already, no problem. We just wanted to get a sense of what folks are already doing. And while you're doing that, I am going to go ahead and just get started, keep going with our introductory slides. So our training team is Dr. Michael McDonald, who is a professor, a clinical psychologist, and he has been researching contingency management for at least a dozen years. He always will let everybody know that he even does contingency management on himself to reinforce his daily running program for himself. So every single day, Mike runs and gives himself a reward. So
I don't give rewards anymore, Sarah.
Oh, right, because
the first year, just like we don't give rewards people for 13 years.
Thank you, Mike. And then I am Sarah Parent. I'm assistant clinical professor at WSU as well, and I am our lead CM trainer. So I learned contingency management while coordinating an intervention study that is looking at a few different versions of contingency management for folks with alcohol use disorder and serious mental illnesses. And then have now pivoted to starting to teach a variety of settings how to do contingency management and most specifically for stimulant use disorder, because as you all know, that is where there's a great need and a lot of evidence for contingency management being very helpful for folks who are using stimulants or struggling with stimulant use disorder. We also have Dr. Andre Miguel. He is an assistant research professor at WSU. He has been a practitioner of contingency management for a lot of years. He has done contingency management in Brazil and really was able to make it culturally centered for a variety of settings there, and has a lot of sort of real world on the ground experience doing contingency management. And then we also have Rachel Shin, who's an MSW and is one of our CM trainers. She also coordinates the same contingency management study that I just mentioned, and has gotten some experience delivering contingency management daily for at least a year now, and also has prior experience in substance use disorder treatment, and so can really kind of relate to settings that have been using other interventions for substance use disorder and how contingency management might fit into those settings. So Andre and Rachel and Mike, if you want to wave, hopefully you're kind of pinned at the top of and unmute and say hi, and then that will kind of get you at the top of everybody's list. Okay, and then Lindsay, do we have a way to show the results of those, the polls, or I don't know if everybody, there we go. So it looks like the vast majority of people, are not using contingency management already. But for those who are, there about a third of you are targeting drug abstinence. Few people are targeting attendance, and then there are some other targets. So for those of you who are targeting other behaviors, if you could throw that into the chat, that would be helpful for us to know. Thank you so much. And Lindsay, if we have most of the people in from the waiting room, I'm just going to make sure to go ahead and continue on to the content today. So webinars are tough, right? We have a big group here and we won't be able to have, we have so much content to cover, we won't have much time for interaction, but we do want to encourage you to enter your questions into the chat. And Mike and Andre and Rachel will do their best to actually answer some of them as we go, or basically whoever's not speaking is going to be available to answer chat questions. And then we also might pause the speaker and have them address the question out loud. We'll have a few different question points throughout the day, and then we're going to have a lot of time at the end for discussion. So we are going to do a breakout room where you can discuss in groups and then bring those questions to us at the end. Okay. So the agenda for today, we're going to do a quick review of what we went over last week. And then we're going to start teaching you how to design an evidence-based contingency management program specifically for stimulant use. So we're specifically targeting stimulant abstinence in this program. And then we're going to get into the details of contingency management delivery, what I call the secret sauce, the kind of the art of delivering contingency management, and all those nitty-gritty details, because this is your nuts and bolts training. We're going to talk a little bit about challenges, regulatory considerations. We're going to demonstrate the voucher tracker, and then we're going to do go through a visit checklist and really make sure that we have time for group activity at the end. If you notice, I've fit in some breaks on the hour, every hour, a little 10-minute break. But we'll keep an eye on how we're doing. If we have to shave or shorten one of those breaks, we will, because we really want to make sure that you guys get all of the materials. And so our learning objectives today, after this training, you will learn how to design and implement an effective stimulant contingency management program. So again, specifically targeting stimulant abstinence. You're going to learn about the special sauce of contingency management, which is escalation, reset, and recovery. You're going to learn how to conduct a visit. You're going to learn what's a little bit different about urine testing in contingency management. And then you're going to learn how to make sure that your program is compliant with federal regulations. So tools that you should have been emailed already, the contingency management for stimulants manual, the CM voucher tracker, which is an Excel sheet. And if you don't have those already, you should be in contact with Linda Barker, who has been coordinating these events. So if you haven't received those, please let her know. We'll also have our email addresses in the chat or at the on one of these slides. Okay, and with that, I'm going to pass it over to Mike, who is going to do that little contingency management review with you all.
All right, good morning, everybody. Thank you for being here. Thank you, Sarah, for kicking us off. So I guess a couple things I wanted to sort of reflect on. We didn't ask you the questions about your setting because we've been working really hard with Laura and with Linda and Amy too, and then also with the ADAI UW team that a lot of you have worked with for a while to sort of get a sense of what your settings are and learn some more about them. And we're hoping to, as we go forward, we're working with you, we're going to learn even more. And I mean, wow, it's so unique what you're doing, the work that you're doing, the work that we've been doing around opioid use disorder and treatment for opioid use disorder has been so innovative. Whether folks are in jails or even a fire department, it's really exciting. The work that we're doing at hospitals or in other settings is more typical of sort of where we're training people to do contingency management in both Montana and in California. So here we're jumping in on all these different settings. So we want to recognize that some of the stuff we're going to talk about, you'll be like, what? How am I supposed to do that in my setting? That totally makes sense. And please hang in there with us because we are here after the training to figure out how we can make it work. And And so that's on one side. We're here to totally support you and work with HCA and with other partners to make sure that we can support you in doing this work to really help get this out there for people with stimulant use disorders. At the same time, I really, really want you to think about contingency management and take it seriously and take the model that we're training you seriously and adherence to it seriously. And the way I want you to think about that, for those of you who are doing buprenorphine work or have done buprenorphine work in the past, right? With buprenorphine, especially when it was first started, people were very skeptical about it. They said, you know what, that's just another drug. That's a drug you can get addicted to. People are just going to divert it. They're going to give it to other people. They're going, and so it was closely regulated. It's still carefully regulated by the government, right? And for those of you who are started out at the very beginning of buprenorphine and remember how closely it was regulated, that's where we are in contingency management. So we are there right now in contingency management. We are like phase 1 of buprenorphine. The federal government, although it's a supportive federal government, is watching us carefully to make sure that gift cards are not being given to patients in a way that could help you make money as an agency, which is not happening. But they're worried about that. That has happened in the past in healthcare. And they're also worried that people are going to pocket gift cards and walk away with them. And that gift cards that the state's providing or that other states like California are using Medicaid money to fund. So I want everyone just to think about that as we go forward, that the model we're teaching you is the best way, and the things that we're going to be doing, the work we're going to be doing with you all is the best way to sort of protect us all and to really do this the right way so that those constraints can be lifted and we can start doing some other things. So we can talk more about that later. I just wanted to give that preamble, and sorry, Sarah, I know I took more time than I was supposed to. So next slide. And sorry if we had some issues with the poll. Thank you all for sharing anyway. Okay, so I'm just going to touch on some things we talked about for those of you who maybe didn't make it to our overview training, just to give you sort of the basics, like big picture of where contingency management comes from. So contingency management is based on this idea of a pharmacobehavioral theory of substance use. The idea here is that drugs are powerful reinforcers, right? Reinforcers are things that that increase the frequency of a behavior. So drugs are, you can get addicted to drugs, including stimulants. So when I inject methamphetamine, I immediately feel good. I have a sense of euphoria, right? And so it's very reinforcing. It's immediately reinforcing. And it accesses that dopamine pathway in our brain that is our natural pathway. So all of us have a natural pathway in our brain. When someone pats us on the back, gives us a high five, we get a positive review at work, that dopamine system shoots out a little bit of dopamine. And that gives us this natural feeling of, we feel good. And that helps us learn new behaviors, right? That's positive. That's how positive reinforcement works inside your head, inside your brain. And then there's also negative reinforcement. Drugs are also powerful negative reinforcers. So when I've had a horrible day at work, or if I'm struggling with something in my life, a stressful time in my life, or I've been through trauma and I'm having traumatic symptoms of PTSD. When I use that drug or I drink alcohol, those concerns go away. They lessen, right? They don't solve the problem. Using drugs or drinking alcohol doesn't solve the problem, but it really reduces that. It numbs it for a while, or gets it out of my head for a while. So that's negative reinforcement, right? That's when drugs take away painful feelings. So basically what happens is, for many people who are in the throes of addiction, they really are experiencing, just like I am with all my pings I'm getting in text. So I'm sorry if you can hear those. Drugs become their only reinforcer. And so the conclusion is that drugs hijack the reward pathway in our brain. Next slide. Okay, so what contingency management does is we use positive reinforcement to get that pathway back in alignment, or to try to get that pathway back into balance. And so we use non-drug reinforcers, tangible things, and we provide those to people in exchange for evidence of drug abstinence. And so what we are doing is saying, hey, we're going to offer you something else besides a drug that would be reinforcing to you. And we're going to offer it to you at a level that would actually interest you and actually would get you excited about it, because we're fighting against a very powerful reward or reinforcer, which is that illicit drug. Go ahead, Sarah, next slide. Okay, so when we talked about this before, this is a study that's been done over and over again. This is from 1994, so you can increase these dollar amounts a little bit by inflation. This is just a study that's been done over and over again, including multiple times with methamphetamine. These are people who are brought into a lab, into a hospital setting, and they were people who identified as being folks who used cocaine. And they were basically offered, they got approval for this, they were either offered a dollar amount or a line of cocaine. So they had obtained cocaine legally. The researchers, they said, here, you can have this line of cocaine right here for free, or you can have 5 cents. 8 out of 10 people chose the line of cocaine, right? When you bumped it to $1, 6 out of 10 people chose that line of cocaine. When you bump it to $2, and maybe we could increase that to like 4 now, only 2 out of 10 people chose, 8 out of 10 people chose the $2 over the line of cocaine. So for only $2 in 1994, people who use drugs or use cocaine would choose that $2 instead of the line of cocaine. So when we set people who are using drugs up to make a choice towards a non-drug reinforcer, they'll choose it as long as it's in a sufficient amount. And it's not like it needs to be $1 million. It just needs to be a couple dollars. In the model we're going to be teaching you, we're going to start at $10. So we're going to offer people $10 in exchange for a negative urine test for stimulants. Next slide. Okay. And then this is a meta-analysis. This is sort of, but basically the take-home point here is that there's been 60 studies looking at contingency management as an intervention for stimulant drug abstinence and other similar behaviors just in people receiving medications for opioid use disorder. So there's been over 100 studies showing contingency management works for stimulant use disorder outside of MOUD patients. This is just 60 studies, and this table highlights the best ones. 60 studies just on stimulant use disorder treatment with contingency management in the context of either methadone or buprenorphine. And the results are that contingency management has a very large effect. I know some people are joining us, so if you could mute as soon as you join, that'd be great. Thank you. So basically what we find is that contingency management has a very large effect on stimulant abstinence, and it's the best way to help a person stop using or cut down their stimulant use, especially when they're new to treatment or they're still using. So it's the best intervention we have right now for helping people stop using stimulants or to cut down their use. Next slide. Okay, and it's simple. So it's simple in terms of and then Sarah and the team are going to go into, as we go through today, why it's not so simple. So on the other side of the coin, it is simple in that a person's, all they have to do is submit a negative stimulant urine drug test. We give them a tangible reward, which we're going to talk about. We're encouraging you to use gift cards. And then that should lead to an increase in their stimulant abstinence. And I will tell you again that this doesn't work for everyone, right? This isn't like we went over the more detailed research in the last talk, which if you weren't there, you can go back and watch. But really, it doesn't work for everybody. But for some folks, man, it works. And they are abstinent for a long period of time, 4, 8, 12 weeks during the intervention. For some people, it works, but it doesn't cause them, they don't end up being abstinent on every urine test. They might use, and then they might have a positive test, then they'll have a couple negative ones, then a positive test, then maybe a week or two of negative ones. And so it helps reduce people's use. It's not just about abstinence. It also helps for some people reduce their use. And you see the positive benefits in their life as a result of that reduction too. Next slide. All right, so I think I'm kicking it back to you and the team, Sarah.
Yes, thanks, Mike. Great. So we were going to dive right in now that you've sort of reminded what contingency management is. We're going to go ahead and teach you how to design an evidence-based contingency management program for stimulant use. And we're being very specific about that because contingency management, that idea of providing positive reinforcement, of course, can be done in a whole lot of different ways. But as Mike mentioned, the spotlight is on these, us early adopter states, right? So we're among the first few states that are going to be doing contingency management in a, widespread way in a variety of settings, outside research settings. And so we really want to be consistent, to make sure that the programs that we're doing are based on the research, decades of research. It's been researched, for at least 30 years. And we also, we were asked to teach you contingency management specifically to address stimulant use and stimulant use disorder. And so that's what this program design is focused on. And so we're going to start off by describing the basically 4 different aspects of a contingency management program, and how you focus your program based on sort of answering these 4 bullet points. So first you have to define what exactly is that target behavior. What are you trying to reinforce? Which means, what are you trying to either maintain or increase, right? So we want to maintain or increase our target behavior. We need a way to measure that behavior. Evidence-based contingency management is very specifically based on objective measures. And then, of course, we're reinforcing that behavior. That is what contingency management is. So how do you reward that behavior? And then what is your schedule? How frequently are you doing it? How long are you doing it? So we're going to go into some details about each of these bullet points. And I'm going to go ahead and turn it over to Rachel, who is going to kind of drill down on each of those.
All right, thanks, Sarah. So yes, as Sarah mentioned, we're going to be going through kind of what Sarah went over, talking about what all CM programs must have. So let's start with the target behavior. So in this situation, we're really focusing on stimulant abstinence. So whether that is from amphetamines, methamphetamines, cocaine, we want to make sure that we do not require abstinence from other substances opposed to the stimulant. Research has shown that targeting more than one substance at a time hasn't really worked. So we really need to focus on the one thing, the stimulant abstinence. And also a special consideration to have when thinking about this is that sometimes clients could have certain medications that may turn out positive when it comes to the measurement of the testing, which we'll get into the next slide. So for example, Adderall will turn out positive because it's a stimulant. So with that in mind, it's always important to understand, the people that may be in the CM behavior, what kind of medication are they on? What are their prescribed medications? So that's something to think about. So key concept of this slide is that target behavior helps us to focus on something that is attainable and focused, keeps us focused. And then the next slide, please. Measuring the behavior, as I mentioned, with our experience and also through the years of research of CM, our best choice, we believe, when it comes to measuring the behavior is using point of care urine drug tests. You can see that on the slide here, those cups. So these are the reasons why we think that this would be the best option when it comes to measuring the behavior. First, it is objective, so it doesn't rely on self-report. And it is immediate, good for operant conditioning in the design of CM. And also it goes from your hand to the client's hand, sample is collected, back to your hand, and you get the result immediate. And it is feasible. It is quite cost effective for frequent use. Anytime we run out of these cups, you put in a quick order, we get like 20 right away. So feasible, and it is achievable. These point of care urine drug tests have a 2 to 4 day detection window. So you can, in the scheduling of CM, which we will get into as well, it is achievable. Another thing to consider is that these point of care urine drug tests, you don't need specialized training to be able to use these cups to collect the samples. So it can be delivered by anyone in your clinic. You won't need to spend extra time to train anyone to be able to do this part of CM. And we'll talk later on in the presentation about how the urine testing in CM differs from urine testing in many other SUD settings. Coming from an SUD setting myself as a previous social worker in my past life, I know that there are some things that we can definitely address when it comes to how clients may react, getting one of these cups. So we'll get into that for sure. And then next slide, please. All right, so next is reinforcing the behavior. So how do we reinforce the behavior? Remember, positive reinforcement is when you add a pleasant stimulus to encourage a behavior to increase. A very effective pleasant stimulus is a tangible reward. something in your hand, something that they get. In the research, one of the most common ways to deliver this reward is in the form of vouchers that can be traded in for prizes or gift cards. As Mike mentioned when we first started, we find that in our work, gift cards are the most universally desirable prizes and are the easiest for a busy clinic to manage and fit into their bandwidth and workflow. So that is what we recommend. And we'll talk a bit more about these gift cards as we continue on in the presentation or training. Next slide, please. And so what are vouchers? Two models of CM are prize draws and vouchers. Vouchers equate to the monetary value of your choice. Clients are rewarded vouchers each time they submit a stimulant negative urine test. So clients cash in these vouchers for rewards, which, in our case, we're talking about the gift cards, establish base and bonus voucher values so clients earn more as they go. So as Mike mentioned, we recommend starting with $10 and escalating $2 every 2 consecutive successes. So for example, you start at the base of $10, someone comes in, they submit 2 negative urine tests, they've received $12. They've received an escalation of $2 for that week. Following week, 2 more negative tests, awesome, another $2 is added on to that. So that kind of escalation model, which we will definitely get more into. All right, next slide, please. Characteristics of effective reinforcers and why we believe that the gift cards are perfect. So as we mentioned, first off, it is tangible. So rather than intangible rewards like such as the feeling of being more healthy or receiving positive feedback from providers and peers, which we want to make sure to emphasize, it is amazing to receive positive feedback from peers and providers. We're not taking away from that, but we're also saying that CM aids to make sure that the reward is something tangible, that's something clients can literally have in their hands, take home, cash out to reward themselves for the positive behavior that they earned. Also, effective reinforcers are desirable. If your client isn't excited about the reward, it's not likely going to provide enough incentive for them to make the behavior change. In the morning when I wake up, if I know I have terrible coffee, I'm like, what's the point? But if I have this amazing cold brew that I spend some time to make and it's like a routine for me, it gives you more motivation, incentive to get up a bit earlier and have my morning routine, something like that. A bit of a personal example there. So yes, desirable. So for example, so if the result in this situation, if the incentive, is too small, like $1, it may not work. Or if it's stuff that they don't want or already can easily obtain, it won't be motivating for them. So it's hard to anticipate, obviously, what every individual in your CM program will like. So flexibility is key when it comes to this topic. So gift cards are perfect in that sense because they can be tailored to an individual's needs or interests. In each clinic and setting, you can tailor that. And electronic gift cards actually are even more customizable, which we will talk about soon. Another characteristic of an effective reinforcer is that it is immediate. So having pre-stocked physical gift cards or a system for providing electronic gift cards allows for rewards to be given out immediately. And a little tip, there may be some cases where you'll allow people to bank some of their vouchers to redeem later. If you do that, remember to celebrate big in the moment when they still get, so that they get some immediacy from the reward. Yes, so there's that. Escalating is a big part of an effective reinforcer as well. We want clients to have the sensation that they are earning more and more rewards with their ongoing abstinence. It's not like a static thing. They get more and more the more they work harder, the more they work hard on their abstinence or achieving abstinence. We're going to go into the special sauce part of the presentation in a little bit. But once again, another reason the gift cards are so perfect for CM is that they clearly show how the magnitude of the reward is going up over time as the monetary value of the gift card goes up over time. So you can see that more clearly with the use of gift cards. And lastly, we have contingent on the slide there as a characteristic of effective reinforcers. Remember that a key component of contingency management is that the rewards are contingent or tied to demonstrating the target behavior. That means that the reward should never feel like an arbitrary gift from like a well-meaning provider, but rather something that the client has earned through their own behavior choices. So while CM does not incorporate punishment, it does require the target behavior be objectively demonstrated in order to receive the reward. Therefore, it should go without saying that if a person does not show up to a planned visit or submits a urine sample that is positive for stimulants, they will not earn gift cards that day. Simply put, as Mike mentioned, it's a lot, but it's actually quite simple. They need to demonstrate the target behavior, they get the reward. They don't demonstrate the target behavior, they don't get the reward. Next slide, please. All right, so, I kind of mentioned electronic gift cards. So this is a slide to kind of brainstorm, depending on your setting, what feels more feasible, what seems more realistic. And this is some of our information that we gather from research and our experience where, for example, physical gift cards are tangible. The piece of plastic in their hand, it feels good to just give it to them. They leave the clinic with it in their hands. Electronic gift cards are distributed mostly through emails. So that may not be the same kind of feeling or positive reinforcement as a gift card. Both are quite desirable by clients. Electronic gift cards could be a bit more desirable since they can be even more customizable. So it could be like any kind of provider you need it to be, depending on obviously which company you work with for the electronic gift card distributions. Both can be quite immediate, but electronic gift cards you can actually send out right away. But physical gift cards, depending on the stock, making sure you have enough inventory, that's something to just think about. You have to, another extra thing you might have to think about with electronic gift cards, making sure you have in stock with you. Program budget is another thing to talk about as well. And before I move on, I should address an elephant in the room. Thank you. Sarah put this really important thing right here because it is important to talk about. So one of the biggest fears of people who are new to CM is whether it is a bad idea to give someone gift cards because they may be able to trade them for drugs. I get that. I understand that. I also had that question when I was first starting on CM and learning about this entire world. This is one of the reasons why some people have focused on prizes, like physical prizes, rather than giving something closer to cash, like gift cards. However, keep in mind that CM actually has a built-in fail-safe. So what that means is if the client uses their gift card to trade for stimulant drugs, then they will most likely test positive for stimulants at their next urine test. That means that they won't earn rewards for that visit since they use the gift card to get the drug. So, they're going to turn out positive. It's going to show up on their test. So they will quickly see that this strategy really won't work if they want to continue earning gift cards. Also, we have to say that if the strategy to supporting someone's sobriety is based on making sure they never have any money, we as a team foresee that this could pose a lot of problems for that person being able to live a full autonomous life. So just kind of a bigger picture there as well. Next slide, please. So optimize reinforcement schedule. We want to make sure that through these trainings, we replicate what's been done in the research, all the good research that has been done, and try to tailor it and find that sweet spot of being able to move that into these, real life settings. And then so the sweet spot, so there's lots of opportunities to measure and reinforce the behavior and be able to effectively, do the CM in the way that it should be done. But we understand there's real world feasibility to think about, like budgeting, staff availability, client, if they'll be up for it or not. So we suggest 2 days per week program. This still detects most stimulant use and is generally feasible. So there's frequent measurement, frequent opportunities to reinforce, as we said. Also, it should be 2 non-sequential days. So ideally like a Monday or Thursday or Tuesday or Friday. If you're combining your CM program with another, I apologize, my litter box is going off in the back. If you're combining your CM program with another treatment program, such as groups that meet several times a week, it could be ideal to perhaps piggyback the CM on the schedule that the clients have already signed up for. I know when I used to work in a methadone clinic, a lot of our clients had to come into our dual diagnosis counseling program where I worked as a social worker, and they did have groups multiple times a week. So I remember, even although I'm a researcher right now, I think in my mind, oh yeah, I could have definitely tacked on CM to those group days when they were coming in. We'll talk a bit more about settings of CM as they're coming up. So let's see, another thing that is important to say in this slide is this is the most common duration that's found in the research. All these numbers and dates are from the research, obviously. Any less may not allow for enough time to work. Any more may have diminished returns and put more strain on your program budget, which is why we have twice a week for 12 weeks as our optimized reinforcement schedule. CM is designed to help initiate stimulant abstinence by providing program-based reinforcement. Essentially, it provides a therapeutic reward to allow time for natural reinforcers, such as more rewarding relationships to start kicking in the lives of the clients that we're serving. So with that said, I'll hand it back to Sarah for her to review the slides that I've just gone through.
Thanks, Rachel. So hopefully that section kind of helps us know, I think if you know why CM is designed the way it is, then it helps you realize why some of these features we really are locking in. And this is how the contingency management is going to be the most effective, most evidence-based, and most focused program. And so again, this slide basically just reviews everything that Rachel just talked about. So what behavior are we focusing on? We're going to focus on stimulant abstinence, and that means testing amphetamines, methamphetamine, and cocaine. But we are not going to require other behaviors for this reward. You don't want it to be complicated where people, you know, if we're trying to reinforce one behavior, then if multiple behaviors have to be demonstrated, then that operant conditioning gets a little bit confused, right? So sometimes I use an example of, you know, dog training. And if you want to get your dog to lay down, you're not going to ask him to do 10 different things before he lays down, because then he may not even know why you got the treat once he laid down. So that's what kind of how we want to look at focusing your program, that reward is really specifically for stimulant abstinence. And so for this program, you're not going to require other behaviors to get the reward, and you're not going to reward other behaviors other than stimulant abstinence. Again, contingency management has been used for other target behaviors, and very few folks on this call have been using it for things like treatment attendance. But again, for this program, we're going to focus on stimulant abstinence. And then again, we chose point of care urine drug tests as a way to measure the rewards for a real specific reason. So I know that lab tests, some folks are really used to sending out urine samples to the lab to get those quantitative, very accurate stimulant drug test results. But remember, the point of care tests actually have some really great features for contingency management. So they're immediate, which means that you can give that reward immediately because you have the results immediately. And they're simple. Contingency management doesn't need specialized training, so anyone in your setting can administer them. And they're feasible. They're very cost effective. And again, but most importantly, it's an objective measure. So at the beginning of your contingency management program, you're going to be upfront with your clients and patients and let them know that the way this program works is that we want to, encourage you to be able to stop using stimulants. And we're going to, together, we agree that this urine drug test is going to be the way for us to see that that's occurred. And once we see that's occurred, we're going to give you a reward and we're going to really celebrate that achievement. So again, and that reward is what reinforces the behavior. So sometimes we call it a reward, sometimes we call it a reinforcer, sometimes we call it an incentive, but whatever the word is, it's that pleasant stimulus or that good outcome to their behavior choice, right? And so in this program, the simplest way to do that is to provide vouchers that people then convert to gift cards. And so Rachel did a great job explaining the pros and cons of electronic and physical gift cards. They really are, in some ways electronic are the easiest and the most customizable, but I definitely know in a lot of settings, there are folks that just aren't necessarily, comfortable with email. Maybe they have a smartphone, but they lose it a lot, or it gets stolen, or it breaks. And so having access to, and I tell you, actually, another real world thing that I've just learned recently is that two-part authentication is actually making it very tricky for people who lose their phones. So you lose your phone and then you can't even get into your email. And so these are a few reasons why sometimes physical gift cards can just be a little bit easier and more straightforward with some of your clients and patients. But then you're locked in. You have to choose ahead of time. Are you buying gift cards for Walmart or Target or a local grocery store or gas station? It really depends on your setting, and you really want to know your clients and your patients to know which gift cards to choose. And the other tricky thing about physical gift cards is that you do have to purchase them in very specific increments, right? Like $5 or $10 increments. And so I will teach you later how to deal with that, right? Because sometimes you're going to be giving out rewards that are, they earned $12 today. So how am I supposed to give them a $12 physical gift card? So we'll teach you how to manage that today with the tracker. And again, though, that's one of the benefits of the electronic gift card is that you can, give out a $12 gift card. And the other thing that we do recommend is that that you have a very specific protocol for giving out these gift cards, because as Mike said at the beginning of this talk, all eyes are on contingency management right now and all of the kind of groundbreaking programs. And so we want to make sure that we prove in no uncertain terms that what we're doing is a therapeutic intervention and not just an opportunity to pocket some gift cards. And then Rachel also explained that just to simplify things, a twice weekly schedule for 12 weeks is really a great way to replicate what's in the research and do that in a way that fits into the budget that you have to work with, that gives, again, that balance between being able to detect most stimulant use. So, if you space that out on a Monday, Thursday, or Tuesday, Friday schedule, you're really going to be able to detect most return to use with those point of care drug tests. And then you also get that frequent opportunity to reward, right? So twice a week, you're having that little opportunity to check in with your patients and clients, really fortify that relationship. And then they get that reward so regularly that, again, that positive reinforcement has a chance to work. And remember, these visits only take about 10 minutes. So there shouldn't, as much as, it may seem overwhelming to have to see every client or patient 24 times in the course of this 12 weeks. These visits are short, and so tend to work into your workflow a little bit easier than it may seem when you first start to think about it. So I am going to just kind of review then, so of all those details, what can you play with? What can you kind of modify for your setting? And what are we saying, Washington, we want to all do this part the same, right? Because, we're all getting funding from the same source, and we want to kind of have some consistency across the program so we can really get a good sense of how this is being done. And so that's what we mean by fidelity requirement, right? So doing any sort of intervention or therapeutic technique to make it standardized across several settings. We call that fidelity to the model that you were taught. And so we kind of have two different ways to think of this. You can, there are some features that we want you to kind of adhere to pretty tightly, and then there are some that you have some room to customize. So the one fidelity requirement is that this program is for stimulant abstinence. Room to customize, that might be coming more in the future. So, as we learn what behaviors we want to reinforce, we may, there may be times where we open this up to other substances. We may open it back up to, reinforcing treatment attendance or other sorts of targets. So, know that has been done in the research, that does exist in contingency management programs. But for now, we're going to stay focused on the stimulant abstinence. For measuring the behavior, the urine drug tests are non-negotiable. We have to have that objective measure. We highly recommend those point of care tests for all the reasons we already described, the immediacy, the cost, all that. There are a few, we've already had some of the folks that we've taught how to do contingency management give us some reasons why they it may be easier for their program to use a lab-based test. They may have the lab right on site. It may be free for them, these sorts of things. So, on a case-by-case basis, you could consider using a lab, but really we emphasize that the point of care test you already, you will have permission to bill for that. And so that's what we're really recommending for these programs. So how to reinforce the behavior. So what prizes, what reinforcement, what rewards are you going to use? The voucher system, we're providing with a tracker to be able to keep track of it. And so it's already designed for a $10 base voucher reward, and it's going to escalate $2 every week of abstinence or every 2 consecutive negative urine drug tests. And that model is just, again, what you have funding for. We're really lucky in Washington that we've been able to find funding to be able to support this level of reinforcement. And so this is where we're going to have people kind of stay organized and stay all on the same page about that kind of schedule of reinforcement. And we will teach you exactly how to do this escalation and all that in a little bit. But we're a really, really great place to customize is what we already talked about. It's like know your clients, know your patients, and know what kind of gift cards will work for them. So, especially if you're purchasing physical gift cards, do your homework in your community. And then whether you make everybody cash out their gift cards every single time they come in versus allowing them to bank rewards and cash them out later, that can be something that might be a little bit of a site-specific choice. And then just know that the exact magnitudes of these reinforcers may change over time based on funding. So that's something that might be customized or changed in different settings and different programs. But right now, we're going to stick with 10 and 2. I like to call it the driver's school model of contingency management. And then that schedule, again, just for consistency, stick with twice a week for 12 weeks. The room to kind of customize there would be, do you extend the duration for people you kind of lost track of for a little while and you got them back on track? What policy do you create for restarting clients? Especially if they haven't earned the max amount that the program allows for. So you'll see that is, I always forget the exact number because the math turns out a little funny, but I think they can earn a max of $528 a year. And so if they haven't reached that, there might be a way to say, well, I want to keep this person in the program a week or 2 longer because they had a little slip up. We might be able to work with that, and we can talk about that in coaching calls. But the program as it's structured is a 12-week program, and the budget kind of works perfectly for that duration. So we're going to have people stick with that. So why do we need this model of CM? Couple of reasons. So the Healthcare Authority in Washington has secured funding that specifically targets stimulant abstinence. We need an evidence-based contingency management program, and that has to rely on an objective measure. So it has to rely on a urine drug test. The research evidence is stronger for this higher magnitude of rewards. You'll see a lot of contingency management programs that have they're trying their best to work among the, within that federal regulation. It's been very confusing to navigate. And so there was kind of a feeling that because SAMHSA only provides $75 a year for contingency management, there are a lot of programs that we're trying to work with $75 a year. And unfortunately, that's just not evidence-based. So even though that's what the funding was, that program is less likely to be effective. So we really want people, now that we've secured this money, to use that level of reinforcement. Remember, all eyes are on these programs as it's being newly adopted in especially these Medicaid, Medicare environments. And we're going to talk to you a little bit about what these regulatory considerations are. And then we want this statewide consistency, which will just help the future of contingency management, not only in Washington state, but just as each state tries to adopt these models, and then we all kind of learn from each other and see what has been feasible and effective in a variety of settings. So this is a perfect time. We have about 9 minutes until break time. We just kind of gave you a lot of stuff about, why we designed this contingency management program the way we did. So this is a perfect time to take a few questions. Mike, was there anything in the chat that you think would be great for us to address out loud?
Yes, there were two outstanding questions about drug testing. The first one was about false positives on urine drug tests. And so I responded to that. So I responded to that in the chat, but basically we've done hundreds and hundreds of thousands. And by we, I mean, I say I have done, but this team has done hundreds of thousands of urine drug tests. And my side hustle as a researcher is being an expert in urine drug test accuracy, especially the point of care accuracy or accuracy of point of care tests. And so what we do know is that it's very rare that there's a false positive, especially for stimulants. And it's most likely to be because of Adderall. In the old days, when you could get easy access to cough medicines that include stimulants, other stimulant, over-the-counter stimulants, then it was possible to have a false positive from one of those. Also, those were used to make meth. So now those are not accessible. And so we're just not that worried. So false positives are extremely rare. It's more likely what you're going to see is a false negative. If we test 2 times a week, it's possible that a person could go out and use meth like if you tested on Thursday, they could use meth in the evening and you might miss it if you had them come in on a Tuesday or a Monday. That's possible. But again, the benefits of the low cost of the immediate results of the urine testing greatly outweigh any methamphetamine use that we might miss. And if we try to do it 3 times a week, we try to do the urine test 3 times a week, already 2 times a week is going to be a huge challenge in some of your settings where people don't come in that frequently. So asking a person to come in 3 times a week so we could catch all use is probably not going to be feasible. So we'll talk about this more later. I know that, right, Sarah?
Yeah, and I think just one point to that, Mike, is that even this false negative. So if they come to treatment, they submit a sample on a Tuesday afternoon, they use it, and when they come back on the Friday, the test negative. We have to remember that they still achieved abstinence on Wednesday, Thursday, and Friday. So even though the window it didn't catch the entire window, we are reinforcing the last 2-3 days of abstinence. So that's still good.
Yes, for sure. Thank you, Andre.
Excellent point. Yes, which usually represents a big behavior change for a lot of folks that are entering this program. Yeah.
Sarah,
go ahead, Mike. Was there more?
Another great question. These are you all are off to a great start because these are the 2 of the most common urine testing questions. One was about observing urine tests. Do we observe urine tests? And so I don't know if you want to take that on now, just as a quick answer, because I think we're going to talk more about that later too.
Sure. Yeah. We will talk about urine tests later. But what Mike said in the chat, the shorter answer is no, we don't. We really are flipping the script on what it feels like to do urine drug testing. And so for a lot of folks, their experience up until contingency management is worried about getting in trouble when they're doing their urine tests. And sometimes there are really big consequences. It's going back to jail, it's losing your children. And so there's sometimes been a lot of that fear has driven the idea that somebody might, tamper with their urine test. When we really set that tone for this, we're agreeing that this urine test is a way for you to demonstrate that you haven't used stimulants recently so that we can give you a reward. And they see that trust, then you tend to see, less and less. And again, I've been doing urine tests for this study of ours for over 3 years now. And I've had somebody tell me how people can, sort of tamper with their samples in other settings. But really, I think that that trust is something that people are so grateful for. And really each reward isn't that huge, right? So it's different. The consequence of having a positive test is a lot different in a contingency management program, because really we just encourage them to come back in 3 days and try again. And so we find that there's not only is there not a great reason to observe the test, there is a great reason to not observe the test. So I don't know if Andre, if you want to add to that, or Rachel or Mike.
I think we're actually going to go a little bit deeper on this soon enough. So
yeah. Okay, great. Yeah, Andre is going to talk with you all about that later.
There's another question from Jeremy, which is another really good one. That was that we talk about a lot in research and in practice, which is what happens after 12 weeks. Are we going to just what's next? And I think that is a great question. So this again, we're presenting to you the best bang for our buck in terms of what a contingency management model is that would help us deal with methamphetamine use disorder in particular, but all stimulant use disorder, especially in those of you who are working with MOUD patients in sort of the co-use of stimulants. So we're pitching the model that has the most research evidence that we think has the right dose, the right duration to give the best benefit. The question has, and it's always been, most research has suggested an intervention between 12 to 16 weeks of contingency management where we reward stimulant abstinence is the best way to one, to get people to achieve abstinence, and then to maintain that abstinence potential after it happens. But Sarah was talking about my running. So let me just give you a quick example of that. So when I started getting back into running, I got into running because I wanted to lose weight. I was unhealthy, wasn't doing well. And so I came up with my own contingency management program where I got $1 a day if I ran, but if I made it to, and if I made it to 365, I got all that money and my wife let me spend it on whatever. If I made it to 364 and I broke my leg, she got all the money and she could spend it on whatever, and I had to try again. But I never thought of doing it more than, and that was more than 12 weeks to get that. But I never thought of it as more than a year. So, but what happened at the end of that 365 days, it's 366, I went running anyway. I had already signed up for a marathon. I'd lost 40 pounds. I'd signed up for a marathon. I bought a fancy running watch. I bought a marathoning magazines. I started to move into this other world, like into this new, these other reinforcing activities in my natural environment. So that's the concept. Is what we're doing is we're going to provide these tangible reinforcers to people to help them acquire and establish abstinence or reduce their use so that they can access the other natural rewards in their life. So maybe they'll get it together enough in life to be able to go down to that housing case manager and meet with them. Maybe it's that they'll get to have more frequent visits with their kids if they don't have custody of their kids, or they'll get their kids back in their home. Maybe it's that they'll be able to show up to work more regularly, or they'll be able to get a job application out. So it's those kind of things we want to offer, that tangible thing for these 12 weeks. And then after that, we hope the natural world takes over and the clinician, all the other work you're doing with them comes into play. The other really quick thing just to say is that we're doing research on this. We're doing research on this right now to see if we can sort of create a long-term contingency management intervention. But that research is coming out.
And another point is just as Mike mentioned in the beginning, one of the things that happens when you're using chronically stimulant use is that drug basically hijacks your reward system, right? And if we do achieve a certain period of abstinence, it's your body start taking control of that system again, right? So you start being less impulsive and you start valuing more rewards, reinforcers that are not related to drug use. So after a period of abstinence, your chance of being able to choose between a non-drug related consequence or drug use is higher. So that's also on the table when we're doing CM.
Excellent questions. I love great questions. Thank you so much for doing a great job of engaging this material, even in this virtual environment. So why don't everybody take a little break, stretch your legs, get some water. Just come back at 9:10. We'll start very promptly to make sure we get through all of our materials, and we'll get into some of these details. So have a nice break. Go ahead and get started just to make sure we are able to teach you all this great stuff. So we already, for those who are just coming back on either through phone or through Zoom, we are resuming on slide number 27, which is what we're calling contingency management secret sauce. It's the escalation, reset, and recovery. And this is really the features that set contingency management apart from other incentive or positive reinforcement programs. So for those who are trying to follow along with the slides that we emailed you, you can scooch ahead to that slide. And again, keep the questions coming in the chat. These have been great. And for those of you who are on the phone, feel free when we get to the end of sections and we ask for questions out loud, feel free to unmute and just kind of chime in. But also just know that at the very end of this whole training today, you'll have some time to ask questions verbally. So with that, I'm going to go ahead and move on. So we talked about the rewards getting bigger over time and how that's a special feature of contingency management. And so I really want to show you this in a couple ways, because it's one of the hardest things to learn about contingency management. It's one of the hardest things to keep track of, the hardest things to understand even why we're doing it. Because boy, contingency management, it's already pretty simple, but it would be super simple if all you did is, demonstrate stimulant abstinence, get a reward, don't demonstrate it, don't get a reward. We talked about how it, in its simplest form, that is how easy contingency management is. But the subtlety, the secret sauce is really what harnesses the positive reinforcement in a way that is even more effective. And a lot of research went into demonstrating that these features really do make a contingency management program more successful. And so it does mean you have to learn a little bit more and you have to understand it. And after a while, you'll find that your clients and your patients completely understand it, and they will tell you where they are in this whole kind of escalation schedule, right? They'll know exactly how much more reward they get today than they did last time. But I want to teach this to you in a couple of different ways. So when I first started developing these teaching slides, it was when we were all in COVID lockdown and my kids were doing school from home and I was working from home. And so I asked my 12-year-old to draw this little cartoon for me. And this is going to be your way to kind of understand what this secret sauce is all about. So when somebody first demonstrates that stimulant abstinence to you, so they give you that first stimulant negative urine drug test and they get their first reward. And this is represented by a balloon here. So the first reward, yay, you celebrate, they get that balloon, it's that tangible reward right in their hand. And then they come back 3 days later and they're negative for stimulants again. And so this time, instead of earning one reward that day, one balloon that day, they earned 2 balloons that day. So there's even more, a bigger reward, a more exciting reward right off the bat, as soon as they're able to demonstrate a week of stimulant abstinence, right? And so every time they demonstrate another week of stimulant abstinence, then that reward goes up. So instead of 2 balloons, then it's 3 balloons, and it's going to go up and up and up. And so that really gets people continued to stay excited about the reward that they're getting. They know that the harder they work, the more they'll get. And then what happens when they do, they might have a stimulant positive urine drug test at some point during the program. And that is very common. In fact, contingency management we pride ourselves on being able to roll with that and to not have that be a big punitive moment. But we do have again, right in that title, contingency management, those rewards are always contingent on demonstrating the behavior, the stimulant abstinence. And so that day they aren't going to receive rewards, right? And we will have a great section today about having that conversation and staying positive. But there are no balloons earned that day. But then as soon as they are able to attain a few more days of abstinence and have a stimulant negative urine drug test, then they will experience what we call a reset, which means they'll go back down to whatever that first reward value was, right? So in this cartoon, it's 1 balloon, right? So they return to 1 balloon. And I'll really emphasize why that's important. It's not a punishment. It just lets people know that there is something to lose from sort of losing your momentum with those continued weeks of abstinence, right? That you really want to hold on to how many balloons you had been earning. And so you explain to people ahead of time that this consequence exists, or this reset exists. And so, more to lose, or if we reframe that, there's more to be gained for keeping that abstinent streak alive, so to speak. And then, but remember, in contingency management, this is a very positive intervention, and we really want to continue to encourage folks. And we definitely don't want one little slip up to turn into giving up. Well, if I have to start all over again and earn one balloon at a time, that's so frustrating, because I was up to 4 balloons before. So the concept of recovery in this model is that they get to recover all of those bonus rewards they earned with only 1 more week of abstinence, right? So they don't have to have 5 more weeks of abstinence to get back up to 5 balloons. And so as soon as 1 more week of abstinence is demonstrated, then they recover all of those bonus rewards, all of those balloons, and away they go. So that, for those of you who are visual, I hope this kind of balloon metaphor is helpful. But for those of you who are numbers people, I'm going to show it to you with math. So remember, we're using a model where the base voucher earned, so that initial voucher earned is $10. So the first time somebody comes in with a negative urine drug test, they earn $10. The second time they come in, they have already demonstrated 1 week of abstinence. So they earned their first bonus reward. And remember, we define that bonus reward as $2. So by their second visit, they've already escalated up to $12. And then again, the third visit, they'll come in and they'll earn $12 again. And then on that fourth visit, remember, every 2 consecutive stimulant negative urine drug tests are a way to demonstrate 1 week of abstinence. So by visit 4 here, they've already demonstrated a 2nd week of abstinence, already earned a 2nd bonus prize, and now we're up to $14. So you could see, if you had a star student, a star client who really was ready to go with their abstinence, and you will see this. You will see some folks who are abstinent the entire 12-week program. It is, maybe not the most typical client, but it can happen. And so if they were negative the entire time that they're in the program, then by that 24th visit, they would have earned 12 bonus rewards on top of that initial $10, and they would take home $34 on that last day. And I'll be going over those details when we go over the voucher tracker, but I just wanted you to see kind of with numbers how this escalation works over time. And then what does the reset look like with numbers, right? So again, let's just say that this client came in and, the first 8 weeks of the program, they were on a roll, and they had earned up to 8 bonus prize draws, or sorry, not prize draws, vouchers, 8 bonus vouchers. So they took home $26 on that visit. And then they come in on their 17th visit and they're positive for stimulants that day. So that, again, that's what we mean by contingent. They don't earn vouchers that day. So no gift cards taken home that day. But they returned to their abstinence, or that, they just had a brief momentary return to use, and then they attained abstinence again right away. And so when they come back in, they're going to earn $10 that day. And then remember, though, we don't want a slip up to turn into giving up. We want to inspire people to return to that abstinence as quickly as possible. And so again, even after that 1 positive test, they reset down to $10. And then as soon as they get 2 negative tests in a row, then they have recovered all of those previously earned bonus rewards and another one, right? Because now they've demonstrated even 1 more week of abstinence to you. And so they go from $10 up to $28. And we will kind of give you you'll practice how to say that out loud to your clients and your patients, even right on that first day when you're explaining the program, because they want to know ahead of time that there's something to lose here. If I return to use, I'm gonna not be able to earn $26 per visit anymore. I'm going to return back down to that 10. So I know in the back of my head that's coming, but I also know that, I'm not going to give up when that happens. as soon as I can get back on track and get 2 tests in a row, that I'm going to get back to that level of reward that I had earned. So again, this is a little bit complicated. I don't know, you can show of hands if you're feeling a little lost. But I want you to know that we do this for a reason, right? So I give Terry the honors here to say, why? Like, why are you torturing us with this? Why is it that we have to make it this complicated? And again, I want to emphasize that that escalation gets people more and more invested in staying abstinent, right? So they really want to achieve that behavior longer and longer. It keeps things interesting. It keeps their attention. It allows that magnitude of reward to keep up with the magnitude of their effort, right? They're really doing great. And that reset is, again, it's not a punishment because this isn't a punishment-based intervention. But the way I describe it here is not only are we talking about, losing that, say, $26 level of reward. I really think that the other thing that's at play, as I've watched people go through this in the last few years in our research study, is that people really also get kind of invested or attached to their progress, right? They're really happy that that dollar value also represents how long they've been abstinent. And they want to kind of keep their progress. And I always use a video game analogy here because I have kids that play video games and I don't really play video games. So all I know is that when I tell them their time limit is up and they're in the middle of a level, they'll say, no, I can't stop now because I'll lose my progress. And I used to not really even know what they meant by that. But what I understand is that they have to start over again and they hate that. And so that's also sort of what's at play here with designing that reset, is that you want people to feel attached to that progress and to keep up that momentum. And again, though, what we call recovery in this model of CM, so different than maybe what the word recovery means in substance use disorder treatment in other ways, but recovering those bonus prizes quickly without having to, when I describe this to people, I use a different kind of metaphor. I say, okay, you're not going to have to climb that ladder one rung at a time again. You are going to be able to get back to that, that $26 and even more as soon as you're able to show a week of abstinence again, or 2 negative urine tests in a row. And so that helps people stay encouraged, right? Because you don't want to lose people. And we really, again, this isn't about punishment. It's about a little bit of, that accountability and also staying invested in keeping their abstinence rolling along. So because this is sort of one of the trickiest parts, details of contingency management, I can pause briefly here to see if we have any questions about this, but also know that if your questions are just like, how am I going to keep track of this? Then don't worry, that Excel tracker that we provided is going to do it for you. So you don't have to be like, are they at 20, when they recover their bonus straws, are they at $28 or are they at $26? I'm confused. Don't worry about that. Technology will do that work for you. But if you have any questions about the concept in general, we can take them. Otherwise, and it looks like I'm not seeing anything pop up in the chat. So I am going to go ahead and pass this back to Andre, who is going to talk to you more about the art of contingency management, how to have those contingency management positive conversations. And for everybody who's following along with their slides at home, we're on slide 33.
Let me unmute here so you can hear me. So for me, the art of contingency management is really the art of providing care, especially mental health care. So while research should be 100% science, care is actually as much of an art as it is science. And if you want to move to the next slide, and for me, I think that's particularly important when we're talking about treating people suffering from substance use disorders, because our society in general will be very will be a punisher with people that suffer from this disease. It's very common to suffer from social punishment. People think you you may be, you have a lack of character at least, or you might be involved in criminal activities, you might be dangerous. There's a lot of negative feelings towards people that suffer from substance use disorders, and they can feel that, right? And so for me, I really believe that, and if I were to write a book about the art of being a clinician, I would, the title would be something like Intimacy as a Therapeutic Approach. And I really believe that. So it's really important to show them a positive approach to their treatment, right? Our power to treat these people exists only if they come to our treatment. If they drop out, we have no power to treat them. So we really want to encourage them coming back to our treatment. And we should really focus in what, as behaviorists call it, differential reinforcement, which is instead of trying to look at the behavior that we don't want to be occurring, we want to keep an eye on the behaviors that we want and are occurring. So for example, obviously, we're going to be focusing in the urine drug testing, especially if they're negative, right? We're going to encourage them. But if they're positive and they test positive, we shouldn't waste a lot of time there. Instead, we should look at the other things that are occurring. So, and really focus in not punishing or providing negative consequences. So the next slide, please. So one of the things that usually in our approach, we're very empathic. We're always happy that a participant comes to treatment, right? I really believe that the fact that they came to treatment is in itself something that we should be valuing with them. So if they come to treatment and they test negative, the way I like to talk and teach my students about this is, but this is a team, right? It's a team effort. They're doing lots of the works, but you're part of their team. So when they achieve that abstinence, it's like your team just scored a goal. You should be really, really amazed with that, because you're being able to achieve something that is extremely hard. Achieving abstinence, especially for people that have a difficulty in achieving a small portion of abstinence, achieving that and being reinforced and being valued for that is super important for them. And I would actually say that they value the social reinforcer that you provide to them is almost as important as the reward itself. So I would always keep in mind that when they test negative, you want to celebrate them. You want to remind them how much they won, how much they will win in the future, the period that they have been absent. All of those things, pointing that out all of those times is super important. At the same time, if they test positive, we shouldn't put much weight in that positive result. What I like to say is like, well, you were going to test positive. You could just not have come to treatment, yet you decided to come. You're here. And for me, coming to treatment is 50% of treatment. There's a few other things that we need to work with, but the fact that you're coming here, even after recent use, is really telling me that you're committed with this. And we need to figure out what happened there that you couldn't achieve those 2 weeks. And the good thing is, you get another chance. I think substance use disorders have there's two sides of it. One side, you're going to be struggling with your entire life. It's a chronic disease. You're always going to be to have that as part of your life. But the good side of it is you can always try again tomorrow. And with the CM procedure, you don't need a long time of absence to be valued by your community, to be able to access rewards for achieving those goals. So really praising the things that are occurring. The other thing I like to praise, if participants, sometimes they come and their therapeutic binding with the provider is very high, they'll say, I'm gonna do the exam, but I'm gonna test positive. And we can tell them, you're telling me the truth about recent use. That's also very important. The fact that you're telling me that. In fact, when you're doing the urine analysis test, one of the things that we see is that the accuracy of the self-report also increased because they know they're doing the test. So I think all of those fall in that category. And one other thing I would say, sometimes what happens is that you do a urine screening and they test positive, and the participants say, but I've been abstinent for 4 weeks. You shouldn't really challenge that and focus and say that the UDS is telling you otherwise. You should say mostly like, well, I believe you. Unfortunately, in order for us to give you this reward, we need to have the test negative. This may be an issue of your metabolism is slower than most people, but if you keep on absent for another 2 days, I'm sure the test is going to test negative. So you throw in, you believe them, you reward them for telling them, you show empathy in what they're saying, but at the same time, you say, I can't really give you any rewards because it's really based on this objective measure. And I would be liable if I were to give give you that. So I think that those are some points to be focused with. And then next slide, please. And then now we're going to get really in the details of how to do CM, starting with the urine test. And so I would start focusing actually on the right column. So usually in methadone or bup treatment settings, we have this relationship with the urine exam that is very punitive, right? So there's a lot of backslash from practitioners and from patients when they hear this idea they will have to be testing for stimulant use twice a week, because historically we use the drug tests to enforce abstinence, and if they're abstinence, nothing good is coming out of that except the fact that they're probably achieving their goal. But if they're positive, then they have very serious negative consequences, like losing custody of their children, maybe losing I forget the name, when you're out of jail, you lose your probation and you have to go back to jail. So all of those consequences are very negative. So usually if you have an instrument that's signaling no positive consequence if you're doing the right thing, but it's giving you massive negative consequences if you're doing the wrong thing, obviously your relationship with that instrument is going to be negative. CM does the opposite thing, right? We don't apply any form of punishment if the test comes out positive, but if the test comes out negative, they receive that kind of reward. That's one thing. The other thing is related to usually we do lab tests. And the problem with lab tests is that it's going to take a while for your results to come. And the immediacy of the results is super important for us, because we know in nature, people that suffer from substance use disorders and related to that hijacking of the reward system tend to be very impulsive. So they really value immediate consequences, even in smaller amounts, more than a long consequence occurring sometime in the future. So we really want them to submit the UA, which means that they did the right, and the UA, I mean the urine drug test. And that test, if the result comes out immediately and we're able to immediately give the electronic gift card or the gift card, that association between the target behavior, achieving abstinence, and consequence, obtaining the rewards, tends to be stronger. So the reinforcing effects tends to be higher. So that's particularly the main reason why we really want to use point of care testing. And then, as Mike mentioned, the knowledge is on CM efficacy is really on 12 weeks. We really want to maintain that occurring for 12 weeks. If we're doing more than 2 times a week, there's a higher chance that we have a false positive, like Mike mentioned. For example, if we're doing Monday, Wednesday, and Friday, they come Monday, they test positive because they used on Sunday, but then they come on Wednesday, and they didn't use Monday, Tuesday, and Wednesday, but they are still positive because of the use they did on Sunday. That's not good for us, because what we really want to do is reinforce that behavior of achieving that period of absence, right? So 2 weeks a week is really the ideal scheduling, and we know that 12 weeks, 3 months is a lot, especially for those that achieve, and it's around 15-20% of them that achieve complete abstinence throughout those 12 weeks. 3 months is a long time for you to change a lot of habits, because when you're achieving abstinence, you're not sitting down on a chair waiting for your next text to come. In fact, not doing anything is actually a risk factor for relapse. I like to say it's like trying to balance yourself in a slack line. You know those slack lines that you have? If you try to stay still, you're gonna fall. You need to be moving. You need to be engaging in other behaviors, in other repertories not associated with drug use. And that's gonna lead you to other more naturalistic reinforcers. So at the moment that we take out the CM procedure, they will have access to these other social reinforcers, and that probably will keep their behavior. Like with Mike, the endorphin, the pleasure that he learned with his workout, with his running, is probably what's keeping him doing nowadays. It's not the $1 that he would get anymore. Okay, and with that, I think I finished this next part. The next slide, I think, it goes to Rachel. Oh, and then there's a lot of ways that we can measure, actually. So sorry about that. This is me still. There's a lot of ways that we can measure the validity, and it's all going to depend in what you want to use. So usually those urine cups, they have a temperature gauge. So the urine needs to be hot, or means needs to be fresh. There's also a creatinine test. So you know that that's actually urine and not just water. Oh, and so and then there's the separate test strip. So there's different ways for you to make sure that the validity of the test is high. But like Mike mentioned before, I don't think that should be a big issue, especially if you're using the point of care test that we're suggesting that already comes with the temperature. This should be fairly easy and accurate.
Excellent. Thanks, Andre. Some great stuff to think about in terms of reframing the urine drug tests. And because we're doing great for time, we could pause here for a quick moment and just see, I don't know, Mike, if you notice any questions coming in via chat that we should address now before we move on to some recruitment strategies and some thoughts about the variety of different settings.
So I'll just mention one last thing, Sarah, since we have time. There's actually some good studies showing that after you incorporate CM in your clinical setting, both providers and patients disclose that their relationship, their clinical therapeutic bound with their providers and vice versa increases. So they start liking more their providers and vice versa. And this thing of both of them cheering the outcomes together as a team has also a very strong binding effect. So I would point that out.
Thank you, Andre. And I loved how you brought that spirit to the art of CM, and the metaphor that I want to take away from how you described it to everyone is that it was like our whole team scored a goal. I loved that. So it really is kind of the therapeutic alliance really gets reinforced. We've also had groups that we've taught how to do contingency management tell us that once they learned how to do it, and this would be like, you know, nurses in an outpatient substance use disorder treatment setting say that doing the CM is their favorite part of their job, and they wish that they didn't have to do the other part and they wanted to just do the CM, because it's really so fun to be able to have that relationship with the folks that you're doing CM with. And so there's that teamwork, but we also can sort of, you know, if we want to keep our for Andre's sake, I'll say our football metaphor going, our soccer metaphor going. They did score that goal though, and we would really want to celebrate them. So it's a sort of a team effort and really honoring the work that they've done. So thank you so much for your wisdom on that, Andre, since you've done that, been a person to deliver contingency management for years and years and years.
Sarah, just so I just want to follow up on what you said really quick. Sorry. That actually the nurse said she was going to quit unless her boss let her do contingency management full time. And so we all know how hard it is with workforce right now. And I think this is really something, and burnout. And so I really want to validate what Andre and Sarah are saying, which is if once we get this working and once you get it integrated into your workflow, which is a totally new way, you know, we're breaking ground here. You know, it really is fun to do.
Yeah, and Rachel shared her experience as well, having done contingency management and kind of comparing it to other treatment modalities she's used in the past. That it's kind of an honor to be able to have that relationship with our clients and patients. Okay, moving on to keep us on schedule. Rachel is going to help you with some recruitment strategies, and I'll just start by saying that this may be new to a lot of folks. So sometimes, you know, you think recruitment, I have more patients than I can handle already. So you may not think that you have to go out and get people enrolled in your program, but you'll find that at least the folks that we've been teaching contingency management to so far, they have actually identified this as a surprising challenge that they didn't foresee. And this does have a lot to do with the fact that folks, in particular folks who are struggling with stimulant use, don't necessarily engage in treatment at a frequency that we see in other mental health or substance use situations. And so you actually do have to put a little effort into making sure people know your program exists, make sure they know it's something different, and that it might actually encourage people who are sort of resistant to other treatment might actually finally really want to engage in this treatment. But there is a little bit of an art to figuring out how to get people in your door. So Rachel's going to give you some good tips on that.
All right, thanks, Sarah. You already hit on some really important points that CM is not only, as we saw from the poll in the beginning of the training, it's sort of a new thing for many of us here, which is, one of the reasons why we're here today as a team to talk more about CM and how cool it is. But it's not only for like the clients and the patients, but also for the people that you may be working with, whatever setting you're in. So that's one of the points where one of the ways that we could focus on recruitment, because without participants and clients being able to potentially benefit from CM, there is no CM program. So we have this good news and we really want to get the word out with this really cool new thing that has evidence, that is evidence-based and has helped a lot of people achieve abstinence in the past. So one way that we could target recruitment is presenting it, doing maybe like a quick elevator pitch in staff meetings, like, hey, so and so is going to come in and talk about CM, a new tool. As a clinician, in my past life, I would always say, like, I have like a toolbox of different things that I could use to help different clients, because everyone that ended up on my caseload, there were so many reasons why I was there working with them for that time. So the more as a clinician, I felt I had different ways to help participants, I'm in the researcher mindset, help clients and patients, the more I felt just kind of at ease of, okay, this is going to work for this person. This could really help this person. And as a social worker, it's all about finding those resources and services that could help the clients in whatever way they need. So that's why recruitment is so important, because we don't want to just keep this to ourselves. We want to really reach out to anyone who could really benefit from this. So one way that's really important is, we mentioned caseloads. Depending on your setting, that might be a different term, list of clients you're working with, caseload, whatever it may be. The first thing we can really do is identify eligible existing clients. Really think of the people that you meet on a week basis, on a day-to-day basis, whatever your frequency may be, and think about who could really benefit from a program like this. And that you could end up with people who maybe you might have had a harder time engaging with, clients where you're like, I really want to help this person get closer to achieving their treatment goals, but this hasn't really been working. Their attendance might not have been, the best, and you're just having a hard time engaging with them. Those could be certain clients that could really benefit from CM, or people who you have I feel like another thing to consider is a lot of clients have been in and out of the doors of a lot of different treatment settings. So they may feel disillusioned, like, I've done all of this already and nothing's really worked. And it's like, well, do we have a surprise for you? There's this actually cool thing that's very evidence-based that we're implementing. And how about we try this new thing out? Maybe instill a bit of hope, because a lot of the times clients and participants and patients, they lose hope in themselves. So it's that initiative, that positive reinforcement. It's, there's this thing that we can do, and I'm here to support you. And that's where that art of CM comes in. And also partner referrals is something to really think about. Depending on your setting, you might have people just put in your books to work with, or you might have to maybe actively reach out. And even working within the community is a huge part of just community mental health and just mental health service equity in general, where clients may be coming in from different sources. So thinking about whether it's from a hospital referral, coming from inpatient out to an outpatient setting as like the next referral source, or Department of Corrections or low barrier housing programs, thinking of the people in your community who are already probably very much benefiting from your program, who could really benefit more from CM, something to think about. And one thing that, recruitment was also very new for me as becoming a CM trainer and provider myself. Actually, today after this, I'm putting my hat on as a CM provider and going to see clients right after this, but is really identify points of contact in your team who really feel maybe more comfortable with the idea of recruitment, or they are really excited about recruitment. We keep emphasizing that this is a team effort, because we understand everyone has different bandwidth, different, availability, and different things that they want to achieve throughout the days or do throughout their days, or whatever title they may have. So maybe they're like, CM is really like speaking to their hearts, and this is really exciting for them. And if that's you could become that point of contact of, actually, I have these clients that could really benefit from this. Actually, I have this contact with this agency, and these people could really benefit from our services and from CM. And like I mentioned, presenting it at staff meetings, or even, old school, presenting flyers. A part of recruitment that we do is we run around the neighborhoods and put flyers in like the local grocery stores and say, hey, we provide this treatment, and like give us a call and we'll help you out. So it's really important to emphasize that CM is appropriate for all levels of outpatient substance use disorder care in settings. It's not just for like the ones that are on the end of achieving abstinence or in the beginnings. It's really for everyone. And I can't leave this slide without saying that to assure that your program is not violating federal anti-kickback laws, when we do advertise, when we do recruit, we can't emphasize that we will be providing money or rewards for participating in the program. So Mike will definitely talk more about this as we get to his part, but we really can't advertise rewards. So advertise the CM, the evidence base, the assistance and support to clients, but we really can't be advertising those rewards. And
Rachel,
Mike, you are muted. Yeah.
could I just jump in really quick?
Sure, go ahead.
So the reason we're kind of harping on this or talking about this for so long on this slide is that over the last year doing this work in training clinicians and teams to do contingency management, again, because we're focusing on psychostimulant use, people, as you know, just they're not as excited about treatment as maybe people who have an opiate use disorder. And you know, of course, our ADA colleagues, and they have done that great surveys of needle exchange clients and found that, you know, relative to people who are using opiates, people who are using stimulants, just like only half of them are interested in treatment. I also see that as half are interested in treatment, and we got to offer them something more exciting and more effective to get that other half interested. But it has been a challenge at all the sites that we've worked with. It has been a challenge to try to recruit patients, and so that's why we're talking about this so much. And one thing that's been a challenge is ASAM levels of care. And I don't know how many of you are involved in sort of that kind of a system and using those different ASAM levels. We've sort of had to really push back with some of our folks about saying it doesn't really matter what the level of care is. If they're an outpatient, they could do contingency management. So I don't know how much it's going to be different. Washington, you all are doing such great work around buprenorphine and engaging clients already in your work that I think these challenges are going to be a little different here than in our other work. So I'm excited to learn more about what those challenges are going to be. But recruitment's been a challenge. The main thing on the advertising is you just can't put out a billboard that says we're going to pay you to stop using drugs, or we're giving rewards to people for not using drugs. You can't do that. As long as we don't do that, we're fine. You can totally have flyers, or you could have brochures on this. And Dr. Peavy was asking if we can share some examples. Yeah, we'll be glad to work with you all to create flyers and share some of the flyers that we do have. Sorry, Rachel, go ahead.
No problem. Thanks for adding that, Mike. That's so important. I used to work in California, so I'm very familiar with the ASAM levels. Yeah, but yeah, so that's an important point. Next slide, please. So this slide is more for us to kind of us and yourselves to brainstorm how CM could look in the different settings that you're in. So whether it's office-based or other substance use treatment settings is what we have specifically here. So let's talk about office-based. You know, maybe you're in a primary care setting. Usually twice per week visits are quite uncommon. I know I don't go in to see my doctor twice per week, but also there's different levels of people, and people come in to see their primary care providers for various different reasons from various different backgrounds. So we understand that challenges of working with CM could be a challenge when it comes to bringing CM into a primary care workflow. However, we do want to pitch that, you know, having CM could provide structure and support that many clients may need in these primary care settings, or many people just in society may need, and a primary care setting could be the outlet or the environment that provides this sort of structure and support for these people. So that's something to consider. And it could also increase engagement in care. That's something we've been kind of talking about throughout this entire treatment, what am I saying? Training, that is the word. Yes, engagement in care through all of that positive enforcement, the structure, and being a team, and, you know, really being an ally to helping people, helping clients, helping patients get closer to obtaining their treatment goals, because it creates a positive tone for treatment, especially for some of the clients that may be more difficult to engage with due to whatever they're going through, due to their actual substance use or whatever it may be, which is where a lot of, you know, the recruitment comes in as well, making a lot of phone calls. Hey, you're coming in today, right? You know, I support you, that kind of, you know, energy with that. Another setting that you can consider is addiction treatment setting, whether it's intensive outpatient or methadone clinics. So usually in these settings, also from my personal experience of having worked in these settings, clients usually attend multiple appointments each week, whether it's to attend groups or to attend individual appointments. So as it says, can be added onto a group or individual appointment. So I sort of mentioned this in the beginning, where CM is, also Sarah mentioned this, it's quick 10-minute visits. So those could be tacked on to coming in for a group on a Tuesday, Friday, do CM afterwards, and then maybe individual appointment can be a separate thing, not CM. So having CM as a part of the entire treatment plan of your clients and patients can improve engagement in treatment and adherence to treatment, and also once again creates a positive tone for treatment, which is, we really like to harp on that. One of the first trainings I ever got as a CM provider is using person first language. Is really important part of being a CM provider, where we're really putting the person first. It's all about that client self-empowerment, where we're here to support you on your journey to obtaining abstinence. And that was also very humbling for me as a clinician. And I think some of my best work really has been when I focus on, I'm not, fixing this person. I'm here to support this client or patient obtain their goals with the toolbox, as I mentioned. So there's that. And then actually, I think with that in mind, let's see, let me make sure to go through my notes. Yeah, CM may be a natural addition to group or individual appointments, and creating the positive tone, help them engage in their treatment overall. And just simply put, it can get them excited about coming in. It's exciting. So just a new element of excitement into their whole treatment plan. And with that, I will pass it on to Mike to talk about budgeting.
My favorite thing to talk about,
Fun.
budgeting. So, okay, and Amy and team are going to jump in if I say anything wrong here. So, so first of all, you are approved to bill Medicaid for the 24 urine drug tests if you would like to. These urine drug tests we recommend are CLIA waived, and so you don't have to be a laboratory professional to use them or bill for them. And we're wanting to make sure to get special dispensation, or just make sure to get this on the state and Medicaid's radar, because most of you are probably not doing 24 urine drug tests over 12 weeks and billing for them. The amazing thing is that I never thought a year ago that we'd be able to pull this off together. The state stepped up and is going to fund $525 maximum per client, remembering that this doesn't work for everybody, and not everybody will be abstinent the whole time. And so the average price will probably be about half of that. So around $300 is probably the average cost of incentives per patient, but the maximum is $525. I think that you're going to be allowed to use. The main budget thing here, so that's the urine testing. There's three components to the cost of contingency management. There's really the urine testing and the funding for the incentives, and then the third part is your staff time. So the most important thing to do, I don't think the state at this point is providing additional funding for staffing for just contingency management. I know they're providing, I think, funding for staffing and for the program, for the SOAR work in general, or for the work you're doing with them already in general. The main thing to remember is do not tie in your documentation a billable encounter where you're billing Medicaid or Medicare to a contingency management visit. So do not write an IOP note, an intensive outpatient provider note, let's say. Don't write a group note that you're going to submit to Medicaid and say in that note that you did contingency management. Write your group note, submit it, and then submit it to your HR, sign it, whatever you do, and then go and open up a new non-billable encounter note and document your contingency management. So you can still do contingency management as part of group. Like you could have people come in at the beginning of group, submit a urine test, have one of the group leaders go and do all the tests, work up the results by, have the results at break or at the end of group, and give out the incentives then to people. But so you could do it as part of that work, but don't document it in the same place. I hope that makes sense. And we'll talk more about this later and as we go on with you all. But so staff time isn't covered, but we're hoping that these additional funding and urine drug tests will kick in. And remember, anyone could do this intervention. You just have to be able to give urine tests and give out prizes and have a positive attitude and get excited with people. And if you can do those three things, this could be a physician that does it. It could be a psychologist. It could be a nurse. It could be a care manager. It could be a peer support specialist. It could be anyone. And it could be a front desk staff or an MA. So staff time, I think, that can mean a lot of different things. And we know the states are already supporting you with some of their contract work just in general and to cover your staffing time for other related services. Okay, am I still continuing on with this one? I guess it's a yes.
Yes, Mike, this will be the last slide before break too.
Sounds good. Okay, great. So the main thing here is just as Rachel was talking about is as we've been doing this work, we've really found that having a couple different roles are really important, and these roles can all overlap. So number one is sort of having a mentor or someone who's going to support you in terms of implementing contingency management. Right now, that's going to be us. And what's cool to watch as we've been doing coaching calls with the folks in Montana, is that we've had some people step up on those coaching calls from some of the sites in Montana, some of the clinics, and start mentoring and coaching and supporting other folks who are just getting started. And so a lot of cross-pollination in terms of your expertise. So that's going to happen at the start. That's going to really be our team. We're here to support you on those coaching calls. And then what you're going to want to develop though and decide on in your team is sort of who's going to be the person who's going to be the lead, like Rachel was talking about. Who's in the person that's going to help develop the policies and procedures that, with us that are specific to your site? Who's going to be the person who's going to be, working to make sure everything's going, to make sure you're recruiting patients, to make sure that it's integrated into your workflow, et cetera, et cetera. And then, so who's going to really be the lead person? And then that person doesn't have to necessarily be the person doing all the contingency management visits. That person might be working with the delivery staff or clinicians. We use the term staff just because we're trying to keep it very general, because like I said, this doesn't have to be a clinician or a clinical staff member that does the intervention. So you may know the person who does the actual urine test, administers the rewards, and keeps clients engaged. That could be a different person than the program lead, and work with that person. I do think it's important just to remember that we are doing this twice a week. So having having two people trained on your team would be one who's a lead and one who's the main delivery person, but then that lead person can step in when the delivery person, or the main person who's delivering the intervention needs to take a vacation or is out sick or whatever. The last thing is, we really want to make sure that everyone in your system knows about this. So you might have supports, and so you could all do two things here. One, you could have support staff that help with some of the paying out vouchers or doing the gift card stuff. So you might, as a clinician or the person who's doing the intervention, not want to be doing the accounting stuff, not want to be responsible for going to Walmart. Or for buying the gift card. So you might need help there in terms of support staff. The other thing, just to be clear, is you really want to reach out to people throughout your system and make sure they're educated about this, because this is something that's new and different. So I'll stop there, but we'll be helping you sort of figure out this, because this might be different with different folks. So I think we have a couple minutes for questions. I haven't seen any questions pop up in the chat, but folks, we could probably take time for a couple questions. Does that sound right, Sarah?
Yeah, we have a couple minutes here. Anything related to just how you foresee it impacting, how you staff your programs, or how you deliver the contingency management, how you do the urine test. Any questions about that? Let's see, we might have something in the chat now. Yeah, I apologize for this. Amy is chiming in the chat, and I also just want to acknowledge that I sort of used the wrong term in that slide, and Mike caught me there. So the 525 are actually, the number is even a little bit more specific than that. I think it's 28 or something. Is how the math works out when you have a 12-week program, and if somebody was continually abstinent, and they get the $10 base reward, the $2 escalation, and we may even, and I'll show you when we do the tracker, we may even have folks, if round up to 530, especially if you're using physical gift cards. But the program, like the healthcare authority, did not have to find enough money to pay every single client that's going to do contingency management $530. And so the way that the contract, I think we're finding a way that they can amend this contract so they say, well, people will still get an average of $300, which is what they funded before, right? An average of $300. Some folks might get that full amount that they could earn, the 530 for now. Some folks won't, may drop out after the first day, or may drop out after the first week, or may not earn any rewards because they, struggled to achieve abstinence during the time they were in there. And then most folks will be somewhere in the middle. They'll have a few missed visits. They'll have a few missed, a few positive samples. And so that's a way that we were able to fund that. But I do want to apologize that I can go back in this slide. Mike explained it better.
So
this
Sarah,
is the max amount of earning.
Yeah, the main point is that we apologize to all of you who are doing contracting with the state, that the state might have to do a modification with your contract. But thank you to Amy and the whole team at HCA and Stephanie, and for stepping up and being willing to fund this at the dose we think will really work, which is really exciting. So I think I see Elsa has their hand up. So Elsa, did you want to go ahead and ask your question?
Yes. Hi, this is Elsa with Harborview. My question was around the Medicaid billing portion, and I was going to type it into the chat, but really just around if there are any codes or specific examples or anything you can speak to around that billing practice, that would be really helpful.
That's a great question, Elsa. And I know it's come up in our work in Montana. And I think my short answer is that we will work on that and get back to you, because I don't know the exact answer and I don't want to get it wrong. So we will get together with HCA and Medicaid and get back to you.
The good news is that these are the kind of details we hammer out in the coaching calls. And yeah, it is different state by state, and our team has been training in different states. So we have to make sure that we understand. And a lot of times we actually tag in the experts, either Amy or Linda on this call, who will be able to make sure that we're guiding everybody appropriately there. Great question, though. Thank you for bringing that up, Elsa.
Thank you.
Yeah. Anyone else with a quick question before we take a break, or not a quick question? It's okay. It can be an involved question.
This is Penny from Klickitat Valley. Thank you, first of all, for this training. We've been looking forward to it. Secondly, maybe you've said this and I just missed it, but I just want to clarify that a missed appointment is the same as a positive drug screen in terms of being able to get the contingencies. Is that correct?
Excellent, Penny. Thank you. I was realizing, this hasn't been emphasized yet. And so if we mentioned it very briefly, but it will be emphasized when I go over how to use the tracker, but you're spot on. So a missed visit is similar to a positive test in that it results in, obviously they can't receive a reward if they're not there that day. So that part ends up sort of taking care of itself, but it also results in that reset where people will reset back down to the initial voucher level, that $10 level, when they return, if they are negative for stimulants. And so we'll go over that. We do recommend that people have an excused absence policy that they use very sparingly, but we do want to support people who plan ahead for missed visits, and especially if it's for really kind of pro-social and drug-free lifestyle activities, or something that they can't get out of, like a surgery or a court date or something like that. But most missed visits will be count as what we call a missed sample, and no reward that day, and reset back the next time they come in. Because we really emphasize attendance is key. That's really what makes contingency management work. It builds that relationship. It gets that frequent opportunities to reward. So even if it's a good reason, even if somebody's car broke down or whatever, and they don't make it in, we really want to encourage people to come in and make as many visits as possible. Great question. Thank you for that, Penny, and I'll emphasize it again when we do the tracker. Anyone else before we take a break? I see something in the chat.
Michelle's trying to
Oh, yes.
It's a question we talk about every day.
Yeah.
Yes, about COVID exposure.
Yeah, I think that is in our attendance policy slide, even have special consideration. What about COVID? Yeah, we want to support people in doing the right thing public health wise. And so we do, in my study, I have people have to miss usually about 2 visits to adhere to an isolation or quarantine protocol. And so, yeah, unfortunately, urine tests don't lend themselves to telehealth very well. So they do have to come in and give them. And so if somebody needs to stay home, please support them in doing that. And that would definitely be excused absence in my book, especially if they're in good communication about it. If they tell you about it later, then, you have to make a judgment call on that. But if they tell you, hey, I just got exposed, or hey, I just tested positive, I can't make it in for a week. Like, yeah, talk about, as Andre says, praise, any sort of behavior that you see as productive. And that is great to tell you that ahead of time. And so they absolutely should get excused absences for those visits.
Sarah, Michelle isn't going to let this go. She said, can you, I'm just teasing Michelle, do we extend it to 12, the 12 weeks?
Right. That's a good question. And our research, our protocol's not, it's just to give the excused absence, but it was still, there's still a couple of visits that you weren't able to earn rewards and the 12 weeks will be over. The reality is that means they won't have gotten to their max possible earnings. And so I think that that's a real world implementation thing that we could consider allowing people to extend, because really getting more treatment is better. So that might be something that we can talk through at coaching calls.
And we haven't decided that. We haven't really decided that necessarily with the HCA team either. Like, we haven't set a policy yet in terms of if people, like, another example would be if you go to jail for 2 weeks, do we extend the program for 12 weeks? If you go to the hospital for other reasons, do we extend the program for beyond the 12 weeks? So, sorry, not for 12 weeks, but for those, for additional time. So we haven't talked that through yet, but we will for sure.
Yeah, those are great questions. Thanks, Michelle. All right, let's let people take a break now. Can we return just 5 minutes this time? So if you could return at 12 after, then we'll get started again. Get the theirs wrong. Usually I'm good with those homophones or whatever, but I am a terrible speller in general. So I'm sure I would reward anybody. I bet you could find 10 spelling errors in my slides, and I would fully admit.
Yeah, and I am definitely not a speller, so I'm right there with you, Sarah.
Yeah. But thanks, guys. Also, this is a product of, I am also a compulsive slide updater. So I'm always trying to make these slides better and really fit them as we learn with each round. We've done this slide deck several times now, but every time I try to improve it. But yeah, so the combination of being a slide updater and a bad speller means that I'm bound to get some typos in there. So I apologize, everybody, and you all are welcome to have a laugh on my behalf. Okay, so we're going to start off this section with Mike is going to talk about some of the challenges to using CM, and then we're going to spend a good amount of time on this voucher tracker. And I'm going to demonstrate how to use it. So for folks who are calling in, you hopefully have the tracker. And it might be tricky for you to follow along. So it might be something that you're going to want to listen to this recording later, or we can go over it in coaching calls. But for those who are calling in, we are on slide number about to be 44.
All right, so these are big picture challenges. These aren't the practical challenges necessarily that we're going to work together to help you resolve. So these are more sort of big picture challenges to contingency management. One is just, and staff, we put staff in there because we can figure a better term, but just resistance to the idea of using incentives. And so that's one part of it. The other one is sort of is how we the idea that we're targeting abstinence and not a different outcome. And so let's talk about the first part. So people have, I still remember my first study when I was at Harborview, and I went down to a clinic, not at Harborview, but a different clinic where we're doing our research. on a contingency management study, and someone stormed out of the meeting, a clinician stormed out of the meeting and said he was going to go immediately and call Maria Cantwell to report the misuse of funds that we're engaging with because we were paying people to stop using drugs. And so there was a lot of that resistance. People who have been through, who have achieved abstinence in other ways, or or have a belief that the other stigmatizing sort of beliefs about how people either have achieved abstinence another way, or have a sort of very specific idea or of how people should achieve abstinence. That there was pushback on that, and similar to buprenorphine, when we first started doing work in buprenorphine as a state, I think we see fewer and fewer of those objections because we all know what we're dealing with, which is a big problem, and people are dying, and we've lost clients, we've lost friends, we've lost people we know to stimulants, into the epidemic we're dealing with right now. And so people are much more open to this idea. And so that's, I think we have strategies for overcoming those things, and we'll be glad to support you in doing that, because that could happen. The other side is targeting abstinence as opposed to like reduction in use. And I want to be really clear, contingency management was developed to add on as an intervention in the context of harm reduction. So during the contingency management was invented in the cocaine or crack cocaine epidemic of the late 80s, early 90s, for people who were in methadone or receiving buprenorphine, who were maybe responding to those things. So they might not be using opioids, but they still were using cocaine. And so it was developed and integrated into methadone initially, and then buprenorphine after that, as a way of treating stimulant use. So while its target is abstinence, the real, we don't require like long-term abstinence. And we also, but it really was designed to be integrated into sort of a harm reduction setting. The next thing is the thing that we're talking with you all about, which is this whole bonus reset recovery thing, which gets complicated and sort of blows my mind sometimes in terms of the way it's complicated. It's super important though for making this work. That's been designed, this whole bonus reset and recovery approach that we talked about, and we're going to talk more about with the tracker, has been designed to maximize the chance that a person will establish abstinence, to help people really buy into their abstinence, to have a consequence. It's not punishment, to have a consequence if a person does slip up. That really keeps people going in between those urine tests. So that's really important. Funding for the incentives, that's been these next two are the two biggest ones that we were overcoming, and it's exciting. Number one is that incentives, where incentives come from, HCA stepping up, they're going to fund this incentives so that you can do a program that really works. And then the last one is this anti-kickback regulations from the Office of Inspector General, or this Center for Medicaid Services. We have to comply with these specific rules so that we don't end up involved in Medicaid fraud. And for any of us I was at the University of Washington for a long time when we had a Medicaid finding against us, and it was not fun. And I wasn't even involved in it, but it had implications across the entire system and cost billions, millions of dollars to the university. So into our healthcare setting. So we really want to avoid any issues here. Next slide. So I'm going to talk about the last point, which is, we'll help you resolve. We're helping you in providing training, technical support on the first 2 points in the last slide. People's concerns about this as an approach, like philosophically, and then also the gift card tracking how many incentives to give out at any particular time. HCA stepping up to the plate to provide funding for the incentives. And so the last thing we really want to be careful about, and we want to work together on, and we're here to support you on, is to comply with what's called a CMS or a Center for Medicaid Services safe harbor. And so the main thing here is, right, we don't want anyone at Medicaid to think that any of us are making buku bucks on contingency management, that you are incentivizing people so that there'll be more, so that you can get more revenue from Medicaid. That's not what you're doing. None of us are making buku bucks in this field. But we want to create a contingency management program that targets abstinence and improve client outcomes, not inadvertently or directly rewarding billable encounters. I hope that makes sense. So that's the sort of overall spirit of this, and this is what we're doing. So the first thing is, we do, literally in California, they had billboards that said, Medicaid enrollees will pay you to come in $100 to come in for a health check. And then those clinics would then do their health checks, which include millions and millions or billions of dollars of fraudulent medically unnecessary exams and tests and things like that. And so we just don't want to do that. We don't want a billboard that says, with the picture of Sarah saying, come and get paid to not use drugs. But again, we can still advertise, and we'll work with you on how to do that. You need to document. You can't just apply contingency management to everyone in your program. So you have to document the need for that person's for contingency management in that person's medical record. So, in your treatment plan, if a person has a stimulant use disorder, you'd want to say, this individual has a stimulant use disorder diagnosis. Therefore, we are going to be implementing a contingency management intervention targeting their stimulant abstinence to help them acquire, reduce their stimulant use. So you just need something like that in that particular person's treatment plan, so that you can document medical necessity basically for the intervention. And I think our approach is, to start with at least, will be people who have a stimulant use disorder. And we can talk some more on coaching calls or later on in terms of what the specific inclusion is. But I think a good place to start with is a person who comes in their assessment has a stimulant use disorder. And then the next thing we're teaching you a research-based program. So documenting that you're using a research-based program, that helps protect all of us from any kind of a Medicaid audit. This tracker that Sarah and the team's going to teach you is really important, because it not only is the way you calculate how many incentives, but it's also you give out at any particular time, but it's also a way for you to document that you are only giving out incentives for negative urine drug tests. That it's a way for you to sort of, if you were ever audited by Medicaid, you could show that sheet that you were giving out the incentives for the negative urine tests, not for other things that Medicaid might not be comfortable with. The last thing right now is we're only, I think, talking about a model of 525 to 530. Just know that if you ever have extra funding, or you do other things or you use incentives, or we decide on a program in the future that offers even more incentives, the main thing is you cannot give a person more than $599 in gift cards, because they're considered cash and that's considered income, and they'll have to report that on their IRS, on their tax forms. So basically, the reason that this point's on here is that if we ever ended up going over $599, we just need to be aware that would be reported to the IRS, or you'd have to report it to the IRS. And then the other thing is we want to do quality improvement. That's why that tracker's there. That would help us do quality improvement, or you do quality improvement, to really see, is this working in your setting? Documenting you're doing that is important. The last point is to avoid, like I said before, don't write a note that says, I did an E&M visit, a medication evaluation for buprenorphine, and because that's a billable encounter, and then talk about how you did contingency management in that same note. I don't think there's anything really wrong with that, because again, we're reinforcing abstinence, not attendance to the E&M visit. But just in an abundance of caution, at least to start with, we're asking that you write that E&M visit. So let's say you are an MD or an ARNP or DNP, and you're seeing people for buprenorphine, and you do contingency management as part of that time. So you want to document, though, that you did the E&M visit in one note, and then a separate note where you do a quick documentation, super simple, that you did contingency management with the person, and you did and they got this many dollars worth of gift cards. So just disentangling those in your, I think, is an extra level of protection for you all. In some settings, people are actually using non-billable providers to do the contingency management and document it just for extra protection. I hope this is something we won't have to worry about in a year from now or 6 months from now, but it's something just to be cautious about. And then, yes, Elizabeth, that's a great question. We're going to be working as a team to create some example documents to share with you all. We have some. We're going to rely on reaching out to our colleagues in Montana who have developed a lot of this, and bring back to you some of what we think are sort of the best examples. But documentation in terms of can be super simple. It can really be one sentence in a treatment plan and one sentence in an encounter note. I think it could be really simple. So we'll be bringing that back to you. Don't forget that question to make sure we answer it in the next few months as you all are getting started. But so we'll be working on that for sure. It's a great question.
Yes, we can take about maybe 4 minutes here before I move on to demonstrating the Excel tracker, just because I know some of these, the safe harbor requirements, or how to make sure we're not getting ourselves in hot water, might have some burning questions, although it looks like, so I'm not seeing any in the chat, but if anybody who is called in, if anybody wants to raise their hand or unmute, we can take a question or two before we move on. Penny, looks like you have a question.
Hi, yeah, so we also give incentives for GIPRAs, which is the government survey we do for our grant. And so if the person comes in for a follow-up survey, complies with that, or they get a gift card for that. So how does that figure in with the maximum in our grant and also this $599? I mean, it's a small award, but I just want to make sure that I'm cognizant of how that works in with the rest of it.
That's a really good question. We all love GIPRAs. Yeah, that's a really good question. So I think, is that money coming from that you're giving out gift cards for those GIPRAs?
Yeah, that's part of our SOR.
Yeah. And how much total, how much do you get paid per GIPRA?
We don't give it for an initial GIPRA, because that's usually their second visit, but we do for a follow-up survey, and I think we do for the discharge also. Those are the two that we have difficulty collecting, and I think it's, oh gosh, somebody's gonna have to help me on that. I want to say $25, but
okay,
I can't remember.
So the main thing to just keep track of is, so first of all, it's a small group of people that will get the full like 530 from the contingency management intervention. And for many of them, it'll be in 2 different tax years. And so, so that's the 12 weeks could overlap with the tax year. So for the most part, it won't be a problem. I think you would want to develop some sort of simple, and then the other thing to say is, like, our university requires that we report it because we're a university. If we give out more than $5.99 in gift cards to people, but that doesn't mean that person has to, one, even file income tax, or if they do file income tax, it's on them to report the income. It's not on us. And so we've struggled with this in our research, but we've come to the conclusion that we just want to make sure we're educating people. So I think it might just be something around, for those people who are getting to that like $400 level in incentives as they're doing really well, you might want to step back and just look at the GIPRAs, have a way to check that and see if they've also done the GIPRAs and been paid for those. In the end, it's really on them to, when they file for the income tax, to do that, not necessarily on you and your agency.
Great, and we have one more question in the chat from Elizabeth. We already document in billable encounters if clients accept or refuse a referral to stimulant use disorder treatment. Is this an acceptable documentation as long as CM is not mentioned? So I think if I'm understanding this correctly, we want to pull apart 2 separate things. So we want to document that that there is a need to treat stimulant use disorder, right? So that you are delivering contingency management to somebody with a documented medical need for it, right? So that's one thing. And then the other thing, we just don't want to document that we've delivered rewards during a billable encounter. So I think these are kind of subtly two separate things. We do want to document the need. And then it's fine if you document in that billable encounter that you refer them to your contingency management program. And then the contingency management note, though, will be something different and a non-billable encounter. So yeah, with GIPRA's chart notes, we want to avoid everybody having to do triple data entry or anything. So we're going to show you how the Excel sheet is kind of a one-stop shopping to document the contingency management, but I do will concede to the fact that there might need to be some other chart noting that goes in there. So that's something you're going to help us learn what's going to work in your setting and how to make sure you keep track of everything. Mike, did you want to add anything to that documentation question?
No, without understanding a little bit more about Elizabeth's question, I don't know if I could give more information that'd be helpful. I think the main thing is we don't want to freak you out about this. but I do think it's something we just want to be really mindful of, that no one particular agency or clinic or program appears to be making money off of. I mean, that's essentially what this is about, is that we don't want to have anybody look like they're making money off of contingency management, or basically off of the incentives. And so you will see more people come to clinic. You will see more people show up to group. You will see more people come to your buprenorphine, med management visits. So you will, it is conceivable that when this works, that people, even though we're reinforcing abstinence, that you will see an increase in your billable revenue. So that's, just be really honest with you. But we don't want to make it look like that's systematic and it's not tied to improved patient outcomes. As long as we make it look like, as long as we demonstrate with the tracker and in your documentation that it's associated with patient outcome, which is the negative urine test. And that's really what's essential. Because that will protect us all from any kind of Medicaid interference. Again, this current administration is not interested. They're very supportive of incentives. It's one of the top priorities. Is the administration supporting getting contingency management out, but that always won't be the federal administration and policy. So there's another, so I can do a DSM for STIMs in a billable and then refer to CM. I think the only thing, just to Elizabeth, I think if I'm understanding your question, and the answer is really, anytime a gift card is involved, don't document it. Don't document that in the same note as a billable encounter. If there's no gift card involved, if you're not giving out a gift card to somebody for contingency management, then you don't need to really worry about it. Does that make sense? Okay, cool.
Great. Yeah, and we can keep kind of either addressing that and the questions at the end. Oh, great. Got a yes. Because I will go ahead and move on to this demonstrating the contingency management voucher tracker to really make sure you get a sense of how to use this tool. And then we can continue to kind of chew on some of these questions, especially at the end when we do our breakout rooms, and then we reconvene for to answer people's questions. So the Excel tracking form that you guys were emailed ahead of time, and again, if you haven't gotten this tracker, reach out to Linda Barker and she'll make sure that she gets it to you. This tool does a lot of things for you. And so if it's maybe not one-stop shopping, it's still going to get most of these needs met here. So one thing that a tracker does for you is communicate between all of your CM providers. So I know in the study that I do, we have 3 or 4 different people who may be seeing any of our contingency management participants at any given time. And so you don't have to remember what happened at the last visit. It is clearly documented on the Excel tracker where they are, what number of bonuses they've been rewarded already, what their last, several urine drug tests were, and whether they have some rewards sitting in the bank for them or not. You don't have to memorize this. It's going to be right there in front of you. So even if you weren't the one to do their previous visit. And first and foremost, though, it records that attendance and urine drug test result, right? So it's right there, and you're going to see whether they came in and what their test results were. And then it's going to do the heavy lifting of calculating the vouchers that they earned that day. So incorporating escalation, incorporating reset, incorporating recovery, all of that, you don't have to be able to calculate that on your own and try to figure out like how many rewards do they recover. It's going to do it all for you. It is also going to show whether you gave out gift cards that day. So did you disperse them? Did the client or patient choose to leave some of that money in the bank? It even keeps track of their total earnings. So if you're looking at how much did they earn in this program so far, it's all going to be calculated there for you. And again, this careful calculation helps us adhere to these regulatory requirements, right? So we know that gift cards aren't going out the door willy-nilly just because we, liked somebody and we were happy that they came into treatment that day, right? That they really are used in very specific ways to people who earned them by demonstrating stimulant negative urine drug tests, and that will really help the program prove that it's on the up and up. We also, you know, if you are giving out physical gift cards, we also recommend that you have some way that people sign those cards out. That's a little separate from the tracker, but again, helps it really account for all those gift cards and why they were given out. So again, that's that next bullet point. It documents that the rewards were always contingent upon the urine drug test results. And it monitors fidelity, which means that you all are doing this the same. It ensures that the program, CM program, you know, that people came in twice a week, and if they didn't make it in, they were marked absent. So that will really help us be able to just kind of see in a snapshot what happened with each CM patient. And then overall, this also can give us some results, right? It can show us, you know, attendance is really key to treatment success. And obviously those urine test results is the ultimate sort of evidence-based or outcome-based treatment where we really have documentation of it. And so all of that is done for you in the Excel tracker. So I'm going to go ahead and drag over a few examples here. Promise I won't drag over my email this time. So are you all looking at an Excel tracking sheet so far? Any thumbs up for me?
Yep, we can see
Yeah.
it. I just
Okay.
want to ask, make sure it's big enough for people to be able to actually read though.
Yeah, do I need to zoom in, anybody? Okay, let's see what I'm seeing some chat, so. Okay. And okay, so this first one, this is a quick demonstration of what the total budget of the program is. This isn't the exact layout of the tracker you're going to use. So I'm not going to spend much time with this, but I really wanted to just show you that in this program where you're going to define that base voucher value as $10 and you're going to define that bonus voucher value of $2. So basically they earn an extra $2 per visit every week of abstinence that they demonstrate. And the per visit cap, this program doesn't need a cap. In other words, it doesn't need to stop it from escalating at a certain point. And so it's just set for an amount that's higher than they'll ever make anyway. But that feature is just in there for other programs that maybe did need to use that. So I just want to show you real quick that if somebody was abstinent the whole time, so it's preset for negative, oh, geez, this one is for the alcohol program, but it's so it's set for a negative urine drug test. And if they're negative for all 24 visits, they would earn $34 on that last day for a total of $528. So that's what the max possible earnings for this program would be. And there are ways that we could use this tool if we ever did need to amend the budget that we're working with. So moving on to, I want to show you the first the full kind of functionality of this tracker, and then you all were sent something that is locked, that you can only input the columns that are meant to be inputted. And that way, no mistakes are made, nothing is changed that shouldn't be changed. And but I just wanted to give you a quick tour of how the calculator was created to begin with, just so that you kind of understand a little bit of the inner workings. But again, I don't want to spend much time with this. So know again that there have been fields that have allowed for the base and bonus voucher values to be created, and a per visit cap if that ever does apply. And then we have columns here for staff initials. Remember, you might have more than one provider doing contingency management, but you might need to look back and say, who did that last visit? I have a question. So some initials there would help. This might be something that also a chart note would obviously create for you if you were using another documentation. We want that visit date. It is important. That is going to be a great way for us to assure that they were offered 2 visits a week on non-sequential days. So those are columns you could input. And then we kind of preset, it's a 12-week program twice a week. So it shows you what week they're on and what visit number they're on. And then this is kind of the first, really important column that you're going to enter. So this has 4 presets. You can enter negative, positive, missed sample, or excused absence, right? So, and it is defined here because this is a stimulant program. It is defined as a stimulant, urine drug test result, and attendance here. So that's how, if you ever were to document, well, what does it mean, positive or negative? The top of the column demonstrates that for you. And then we have the, either the test result, negative, positive, or if they didn't attend, was it a missed sample? That's a no-show. We just wanted to frame that in something that isn't necessarily judgmental, but just matter of fact. And then excused absence. And know that we preset all these to missed sample because that's preset. You don't earn any rewards with the missed sample, and that kind of zeroes out the whole sheet for you, and then you fill it in as it goes. Now, these next columns are hidden on your sheet, but this is the inner workings that all these zeros and ones, and this is where the nerdy Excel programmers helped us develop this. And it's what makes the Excel sheet smart enough to be able to know the difference between an excused absence and a missed sample, because an excused absence, as I realize our attendance slide ended up later in the slide deck than it used to be. So that's why we haven't gone over the difference between missed visits and excused absences yet, but I'm so glad we got that question. So there is a difference, and one results in resetting the bonus vouchers and one doesn't. And so the only way to make an Excel sheet smart enough to do that is to have a bunch of behind the scenes work. So all these columns are hidden in your version, but you will then get automatically generated vouchers earned today, and then the available funds, that's what they will have ready to be cashed out. And then you will enter how much they cash out. It will auto calculate what remains. So if they cash out everything, it will always be 0, or it will show remaining funds as what's left in the bank. Then you can keep some notes on which gift cards you distributed and any other visit notes here. Again, that might end up redundant with a chart note. So, you will get to figure out how to use some of these columns in the context of your setting. I just also want to point out that there are detailed instructions here on the side that hopefully walk you through exactly how to fill in step 1, step 2. Note that the red cells are preset for your program, and then the black cells represent what Excel does automatically for you. And so you will only be entering in the purple columns. And again, the version that you were sent out is locked, so you couldn't even enter in one of the black columns if you wanted to. So with that being said, I am going to go and show you some real life activity with this, and I am going to go ahead and use the version that you were sent so that, I also can't change any columns that can't be changed. So this is sort of a real life demonstration of the tracker. So here's what it looks like with, again, those columns are hidden so that all you have to do is enter a result here, and then some, magic calculations are happen, and then you record how much the participant was given. So let me just get started with showing you that it is, smart enough to calculate this escalation for you, the most simple thing, right? Those rewards have to grow as time goes on. I'm not going to do this for every single example, but to begin with, I obviously could just put my initials here. I could put today's date, which is, 2/9, etc. And then, but I can't even enter anything here if I wanted to. Those are locked. Okay. So, I had somebody come in today and they were referred right out of a, an inpatient residential setting right into my program, and continued their stimulant abstinence. So they were negative that first urine drug test that they came in. So they earned $10 today. That means they have $10 available to cash out. And so we're going to go ahead and give them the full $10 amount. Let's say we're using Tango, which is an electronic gift card program that's really great because they have like, you know, hundreds of vendors there. And so that shows that I gave away $10 that day of Tango, and remaining funds are zero. They cashed out the entire amount that they earned that day. So when they come in, and I'm not going to continue to fill in these just in the interest of time, you obviously know how to initial and date things. But let's just say they were negative, you know, they came back on Thursday and they were negative again for stimulants. And so this time that now they've already right out of the gate, they've demonstrated 1 week of abstinence. And so they earned $12 in vouchers that day. They have $12 available to them. And again, if they just go ahead and cash out the total amount through Tango, then, you know, they have zero left in their account. And again, you would mark that you gave it out through Tango and so forth. So as you can see, negative again. And for those of you that want to challenge yourself, why is it $12 again? Why didn't we go up to 14 right away? Does anybody want to just chime in the chat to see if we all are kind of understanding this? Yeah, it's the same week, right? So they haven't given us 2 more in a row. So they haven't demonstrated their second week of abstinence yet. So still at $12 and still can cash out the $12 and et cetera. Now, what if they come in and, you know, they're positive that day? And we're going to use some of those techniques that Andre taught us that we, you know, we still are very empathetic and engaging, and we're so happy they came that day. We're so happy that they told us that they did return to use the day before. And we say, okay, you know, your urine test results were positive today, no vouchers for you today, but remember you have another chance coming up in 3 days. So again, this knows though that 0 is the answer for vouchers earned today. So there are no available funds. And, you know, you couldn't, if you know, accidentally tried to give out money, it would show you that you're, you know, minus. So you can't give out any money that day. And so let's say this person, you know, just to kind of show you how a real life example is kind of, you know, spotty. They came in, they got right back to it and were abstinent another couple of days. They earned $10, but then they returned to use again. So this could happen a couple of times, right? And then, but then they return and they're kind of off and on here for a little bit. You can see that this person isn't really returning to any of the bonus draws just yet because they haven't strung together 2 in a row. But as soon as they do, now they have demonstrated another week of abstinence. And here we go. Now they're up to a $14 gift card. And so that's just an example of being able to show you how the tracker tracks escalation. So any questions on escalation and reset? And then, sorry, we got to escalation, reset, and recovery, right? So escalation, lots of negatives in a row, reset after a positive, reset after a positive, and then recovery is returning to the bonus. So, so a great question in the chat. Does this happen regardless of the time between visits? No, it doesn't. So that's why we take attendance every time. So let's just say, we'll keep up where we're going here, that this person is due for visit number 10, you know, tomorrow. And we're hoping they come in, we're hoping they have a negative test again, and then they miss it. That is counted as a missed sample. Now it's auto filled with that missed sample. So you might want to add a little bit of, you know, add a note that said, you know, no show, no contact, or it could be car broke down. But, you know, we really use excused absences very sparingly because I've heard the car broke down answer to why I didn't come in a lot of times. So, you say, okay, it's okay. You didn't make it this time. We look forward to seeing you on Thursday, but that is a consequence. They didn't find a way to make it in. So if they didn't make it in, then that counts the same as a missed sample. So let's say they only missed 1 visit, then they will be reset. But let's say they miss several visits, right? And so you tried to contact them on Thursday. They said their car broke down on Monday. You tried to contact them on Thursday, they still didn't come in. This time they didn't, even pick up the phone. And then you try to contact them next Monday they texted at the end of the day that they're sorry, that they had something come up, but they're really going to come in, they're really going to make it next Thursday, and you're so excited that they're going to come back, and they do. And guess what? They're stimulant negative when they come back. Great. Then they've been, then they earned their $10 reward. And again, if they had 2 in a row, they would recover all of the previous earned bonuses plus that extra week of abstinent bonus. So they would continue to earn that way. Also, hopefully that answered your question, that if there's that gap in time, if it takes a couple weeks for somebody to come back, then they would have to, then they would get marked as missed visits. So we don't just pause and wait for somebody to re-engage, right? We really have to mark every visit. You set that expectation right at the beginning of the program. And do they need to have a negative urine test to receive rewards? Yes. So in showing these examples, I showed that people, earned $10 here, but because I didn't cash them out, you see that it sort of ended up in the bank, right? And then I even didn't cash out this next one as I was showing this example. And so now they actually have $26 here in available funds. And hopefully we can, those of you may have already guessed, but why this is $26 is because they had $10 in the bank. They earned $16 today. So they have $26 available to them here. Now, let's say they came in and visit 15 and they were positive for stimulants. So they have $26 available to them, but we don't give out rewards on the day that they're positive, right? Because that's not the behavior we're trying to reinforce. We're trying to reinforce abstinence. So we say, today, I know you have that $26 in the bank. Today, I can't give that to you because remember, I give you rewards when we have a stimulant negative urine drug test. But know that you earned that. That is there for you. So as soon as you can come in and show me a negative test, then you're going to earn that money. And so they come back and and they are negative that day. They earned $10 more. They're up to 36 in the bank. And now you could cash out the whole thing. And now they're back, they've zeroed out their balance. So any questions about that? If they do, just to kind of, usually we get this question. Actually, let me check the chat before.
Yeah, we have a lot of questions.
Okay. You know
how it goes when we teach.
Yeah.
So these are all great questions. Okay, and Penny, you might have to ask this just to make sure. So Penny, follow up on me. We might need to just talk back and forth about this. But Penny's question was, so they may have banked $50, but they would need to come in with a negative urine to retrieve that balance, ? And the answer is yes to that, unless it's the last visit. And then we'll talk about that later. But, or Sarah can elaborate on that, but yes. So they may, then the next part of the question is where we may need more clarification. So they may not get a weekly reward for that negative urine, but they could retrieve their $50 is the question.
So we tell them that once you earn it, it is theirs. And so that has been earned. However, we want to make sure that we're using contingency management to actually encourage the behavior we're looking for, right? So even though they've earned it, if we cash it out on a day that they weren't negative, then we're not reinforcing the behavior we're looking for. So to make sure that we get that straight, this question is a perfect lead up to, should we let people bank rewards, right? Is that fine? Like some people might say that initial $10, they're like, oh, I'd rather save up, or don't give it to me right now. I'm just gonna spend it on something silly or something. I really want to save it, especially in December. We had a lot of people say, I'm saving for Christmas. Don't give this money to me right now. We do want to support people in making their choices that way. But however, there is this risk that if they return to use and have positive urine tests, that they may not get a chance to get that money for a while. And we also want to make sure people feel rewarded in the moment. And while we can celebrate, we always celebrate what they earn that day, whether or not they take it home. But, with that risk that there's a possibility that they may return to use before they took any of it home, right? So we really recommend that people cash out in the beginning, that they really cash out every time they get that reward, they know they can spend it. And Mike also mentioned that last visit, if there's a chance, if somebody returned to use, let's say they had earned, a bunch more rewards and they didn't cash it in because they thought they, were saving for something, and then they returned to use right at the end of the program. Technically this person has $66 in the bank. Now we want to emphasize that they did the work and that they did earn it, and it would be appropriate to cash them out at that point. But this is where we have some subtleties and some things that we may be able to discuss with the HCA about, would this be a good opportunity to extend the program a week or two and just get them to another negative so we can cash them out? Remember, by definition, they've had some positive or some missed visits. They haven't earned the max potential rewards yet. So this example, they only took home $118 and they have $66 in the bank. So they're only in the 200s there. They do have the ability to earn more, and maybe it would be appropriate to extend, a week or two to get to a negative urine drug test where they know that there's, some money in the bank waiting for them. It really is encouraging. And I use the basketball metaphor that you want to leave on a make, right? You want to leave on a negative test if you can. But right now the program is defined as 12 weeks. So that's maybe a subtlety we're going to have to work with. And but in case any of the questions are about this, I am going to show you a demonstration of if you were using physical gift cards in $5 increments. So I'm about to do that. Okay. But before I move on to that, do we think any other
we have one question from Joshua, and Joshua asked if he's missing something, and I was gonna say no, Joshua, because I don't even understand. I'm the expert. So only Sarah and Rachel can help us here, I think. Okay, so his question is, I would have thought that the $2 bonuses would have reset, but I see where they drop back to $10 for the first negative test after a positive. But the next negative is $16 when I would have expected it to be 12. What am I missing?
Awesome. Thank you. This is a really great, it's like he's a plant in the audience to ask the right question to be able to teach the right thing. Thank you so much, Joshua. So that is what we mean by, so when we talk about the special sauce, right, which is what makes contingency management that much, juicier, is the escalation, reset, and recovery. So escalation is going up, reset is returning to that base voucher value after you've had either a missed visit or a positive test. And then recovery, and that's maybe the trickiest one to get, right? I think intuitively people understand escalation and reset pretty well. Recovery is being able to recover all of those bonus rewards with only 1 week of abstinence. And that's where, again, the metaphor I use to study participants or clients to understand this is I say, I'm not going to make you climb that ladder one rung at a time again. You had done great. You were up to, $36, or sorry, you were up to $18 in rewards. And so if you have a positive test and we have to reset you, all I need to see is another week of abstinence, and I'm going to give you back all of those bonus rewards right away. And so that's what we say, we don't want to slip up to turn into giving up. And if people think they're back to square one and they have to kind of plod, Charlie Brown style back up, to get to where they were before, it might feel a little too discouraging. And so that's why we recover all of those bonus rewards right away. Did that make it sound easier to understand?
Yeah, that totally makes sense. I just was confused by what we talked about, where it's going to escalate, $2 for every 2 consecutive negatives or whatever. I expected it would reset. So that explanation makes total sense. And I'm glad there's a spreadsheet.
Yeah, exactly.
I know, right? So when I first started doing this research study, and Mike taught me contingency management, and then he handed me this paper form with little boxes and squares, and you were supposed to put how many we do a prize draw model, but how many prize draws they get, and it's supposed to escalate, reset, and recover. And I called it a bowling score. If anybody is old enough to know that we used to, have to calculate our strikes and our spares ourselves on paper, and it was really confusing. So I was like, Mike, I can't do this bowling score. I never knew how to do it for bowling, and I can't do it for this. And so we got some Excel geniuses to do the hard work for us. So yeah, you're not alone, Joshua.
And Sarah, I would just also point that one of the possible effects that the recovery mechanism has is that it helps a lapse not become a relapse, because they know that if they're abstinent for a week, they're going to go back to that 20 amount that they were receiving just before that lapse episode. They had a lapse. They didn't go back to their old pattern of drug use. That's relapse. One lapse is different than relapsing. However, we know that after one lapse, there's a higher reason that you continue lapsing and you relapse. So that recovery mechanism help us put them back on track by letting them know that you already did the work. You can learn from your lapsing experience. And we definitely want to encourage and value what you're achieving abstinence and going back to track. So that's one of the effects that the recovery has too.
Excellent. Yeah. So basically we're using math and numbers to represent that spirit that Andre taught you all, that, it's really about encouraging this ongoing abstinence and to not get overly punitive about one slip up. And
one other question.
Yeah.
So, I noticed like on there, you have car broke down with the missed sample. We talked about, people that are in COVID isolation or something and kind of the excused absence. Is that an option in the drop down?
Yes, thank you. Before I go on to banking, let's demonstrate an excused absence. Excellent. So let me go ahead and just zero some of this out again so that we can kind of have a clean slate to work with. Yes, because this Excel tracker is smart enough. Let's see if I'm smart enough to drag this. Why am I not getting my draggy thing? All right. Well, I'll just zero out a few at the top. Usually I can drag and drop.
Control Shift down arrow.
Usually I take this little corner and drag it down, but it's not giving me my little symbol. Oh.
Yeah, you should be able to highlight them all and then hit, like just select the top and highlight the whole column there, and then that's weird.
Yeah, I don't know why it's not working the way. Maybe it has something to do with locking the sheet. But okay, so let's go ahead and just reset the top of this a little bit to show that somebody came in, had a few weeks of negative tests and experienced some escalation. So yeah, sorry, I reset these all and then I'm going to make them all negative again. Okay, so they experienced, say, 9 visits, so almost 5 weeks of stimulant abstinence. And, you could be cashing them out every single time here, $14 there, $14 here. Then they're up to $16. And then they're up to $18. And instead of car breaking down, they had COVID. And so they let you know, and they have to do, their 5 days of isolation. And so we're going to call that an excused absence. And we're going to say that they probably are going to end up with at least 2 excused absences, maybe even 3. And then when they return, after, since this was already preset to negative, it's already here. See how they didn't reset, right? So they were up to $18 in vouchers here. And then when they came in after their COVID isolation period is up, then they're right at 20. And they continue on from there. Now, remember, here's something that happens sometimes is you grant some excused absences and you say, okay, your COVID isolation is up at this day. With 5 days, they actually may only miss 2 visits, right? And then all of a sudden they're scheduled to come in for visit number 12 tomorrow. And then tomorrow comes and goes and they never came in and they didn't call and they didn't text and they didn't let you know. So I encourage people to make sure that this is an agreement you have ahead of time, And so in that case, they may have been granted 2 excused absences, but then they missed the visit they were supposed to come back. And then when they returned, you know, luckily they were negative and you still want to celebrate that they returned, but they didn't actually have excused absences for all of the visits they missed. And so that would result in a reset, right? The other thing to show about excused absences is that if they were positive before, then they're sort of already in a reset scenario. So even when they come back and they're negative, they're being reset, but not because of the excused absences, it's because of the positive test before. So this Excel tracker is smart enough to be able to calculate or handle excused absences different than missed visits. Did I effectively demonstrate that? Does anybody have any questions about that?
Makes sense to me.
Okay, great. And so again, we suggest that you use excused absences sparingly so that you're really encouraging. Oh, and sorry, the reason why there's a negative 18 there is because I changed that to a positive, so they should not have been rewarded that day, right? So that, yeah, we really want engagement as best as we can get it, but we also, you know, we recommend that excused absences can be used for things like, you know, weddings, court dates, surgeries, things that are either pro-social events or immovable events or okay, so in the interest of time, I do want to make sure that I'm going to show you guys how to bank rewards. And I can't really reset this the way I usually do. I don't know what's going on today. So I am just going to leave these as negatives, but I'm going to pretend that instead of Tango, that we bought $5 Walmart cards. I'm telling you, Walmart is a favorite. I stock physical gift cards or used to stock physical gift cards until we pivoted to Tango, which was a great thing to do during the pandemic. And Walmart was by far the most popular card that we give out, at least here in Spokane. So I'm going to recommend that your program, even though we're using a $10 base and a $2 escalation, I'm going to recommend you stock $5 gift cards, because I'll show you why. That way you can reward more fine-tuned increments. If you had to wait all the way to 20 bucks to give the next increment of reward, then you don't get to see the escalation quite as quickly. So if they're negative the first day, you still can give out $10 and you'll put that you gave out Walmart. And then they come in and they're negative again. So they earn $12, but unfortunately you don't have a $12 Walmart card to give them. So you're going to give out $10. And look, it automatically knows that they have $2 in the bank. So you gave out $10 in Walmart. If you wanted to get super fancy, you could write $10 Walmart, comma, $2 in the bank. But really this is telling you that already. It already shows that there are $2 remaining. And then so the next time they come in, they're negative. So they earned another $12 that day, but they had $2 in the bank. So they actually have $14 available to them. That's what we mean by available funds. But again, you don't have a $14 Walmart card, so you're going to give them $10. But you're going to celebrate. You earned more today. I mean, I could even show you a bank statement. You earned more today. That money is going to accumulate in your bank, and soon that's going to turn into a bigger gift card. So awesome job, giving you $10 today. Now you have $4 in the bank, right? So that's, again, document that it was Walmart. And now all of a sudden, visit 4, they earn $14 because their escalation is going as we expected. But because they had $4 in the bank, they're now at $18. And if I have $5 increments, I can finally give them an escalation to take home, right? So they can take home $15 that day. It still leaves 3 in the bank. And then so on and so forth. So again, they earn 14 today. They have 17 available to them, so they can take home another $15 card. They've got $2 in the bank and so forth. Here, you know, they can earn $15 again. Now they've got $3 in the bank. So remember that available funds is always adding how much they earned that day and whatever was left in the bank. And as people have pointed out, if they are ever positive, here, then they won't earn any gift cards. They have $3 in the bank waiting for them. And you can let them know as soon as you're negative again, I'm going to add that $3 to whatever you make that day, but they're not going to take home anything that day, right? So it just leaves them with $3 remaining. Even during this excused absences, obviously they're not there that day. That $3 is still hanging out waiting for them. And as soon as they're negative again, they have experienced a reset, but they did have money in the bank. And so, you know, we could argue that that money in the bank is now available to them after a reset. However, because you have $5 increments, this time you will still just be giving out $10, and that $3 is still waiting. And now, lo and behold, they have recovered some of their previous bonus. They have $3 in the bank still, but this is the first day that they get to take home $20, right? So so that's how that works. And with this model, you may end up on the last day with something that is, ooh, well, that accidentally ended on an increment of 5. Let's try something else. Let's try giving them another negative. So this one, they have $151 left in this particular example. Now this is partially because I didn't cash them out. Actually, let's go ahead and cash them out to show a more real world example. So, oops, here they, where did we leave off cashing them out? Here. So they cashed out 20. Again, you're celebrating how their bank account goes up even when they didn't receive rewards this day because they didn't come. But when they returned, they had $10, they earned $10 that day. They did have $7 in the bank. So one could argue that you are allowed to cash out $15 that day. Again, letting them know that's that hard work you did before. You had that money waiting for you. And then here they can cash out $25 and oops, I'll call that just for the fun of it. Okay, and so we ended on them having $33 available to them. Oh, I guess I could have. Darn it, I picked an example that ends on 5. Okay, let's make them positive this day. So they end with $12 available to them. Okay, and sorry if that was going kind of quickly to show you how to end on an increment that's not 5. So they end with $12 available to them, and we're going to recommend that you can go ahead and round up. And so it's going to show, you know, you went $3 over, but look at their total earned is $329, and that is not more than they were allowed to earn in this program. So I'm sure I have some questions on this.
Yes, you do. And I also want to just highlight, sir, that we're about 12 minutes, I think, or 14 minutes over our goal time. I think.
Yeah, and I think we can use this demonstration hopefully instead of the checklist, but it's up to us if we want to move on and tackle some of these questions in coaching calls.
No, I think this is important to stop for questions. So
yeah,
do the gift cards have activation fees for each card? The answer is the ones that we're recommending you use, like Walmart or Target or Tango, which again, we really like this Tango product. They do not have activation fees. The only ones that have like an activation fee are things like Visa gift cards, which we don't tend to recommend those. I think they could be an option in the Tango, but yeah, no, for the most part, the answer is no, they don't.
Yeah, no, definitely. All of the cards that we've used in our study, none of the study participants have had to eat any sort of activation fee. I always forget if we had to pay a tiny bit to set up our Tango account, but yeah, that has not been a factor. So yeah, we do have we wanted to go through a visit checklist that is going to have that attendance policy. See, testing this in the real world, me moving around my slides made me realize that that discussing the attendance policy before the tracker is probably helpful. So let's move on just to make sure that we have time for that, because we are going to let people break into groups pretty soon. So let's see. Oh, I guess I was going to do the slides, huh? So setting clear expectations for your participants ahead of time is really important. So we do emphasize that you use even a consenting process or a client handout. And that is where you explain up front, the rewards are 100% based on that stimulant negative urine drug test. So in that rare case that the person says, but I didn't use any stimulants in the last few days, my test shouldn't have been positive. You owe me a reward. That's where you can just kind of fall back on, remember, we agreed together that we were going to use these urine drug tests. And yeah, it was positive today. That it sounds like you haven't used anything recently, but I bet in a few days, based on what you just told me, it's definitely going to be negative and you're going to get that reward. That sort of conversation. But being able, I've had to do this in real world settings where somebody kind of argued with me about the result of their test. And as soon as I reminded them about the agreement that we made and that we, together we are both obligated to, use that result as the indicator of whether they got rewards, then they were like, oh yeah, you're right. That's what the program, that's how it works. Escalation, reset, and recovery is super hard to explain. So I tried to give you a sentence here. You'll get bigger and bigger rewards each time you demonstrate a week of stimulant abstinence. If you have a slip up, you will reset back to the base amount, but you get to recover all of those bonus draws as soon as you show 2 or more stimulant negative urine drug tests in a row. It's still a mouthful, but people really start to get it in real life. They kind of understand and they know exactly what to expect with their reset and recovery. You're going to, of course, tell them what that attendance requirement is. Get ready. We're going to see you twice a week for 12 weeks. And so that's the expectation. And so that, it's not a surprise to them that you're scheduling 2 more appointments for next week, and that continues on for several weeks. And then we also, again, here's that attendance policy that we promised you. So communicate your attendance policy on the first day. Make sure they know that the expectation is for them to come in twice a week. And, you may have your program set that it's a Monday, Thursday, or it's a Tuesday, Friday program. Whether or not you let a Monday person reschedule for Tuesday is up to you. I would not recommend that last minute, but if ahead of time they said, I had this court date on Monday, can I come in on Tuesday instead? Sure, better to see them than to have to mark, an absence. But most visits are considered no-shows. We also recommend a little flexibility because remember, engagement is key. And, Andre pointed this out, getting people in the door is 50% of our work. And so if you can have that flexibility to say, oh, we expected to see you in the morning, but your car broke down and your buddy gave you a ride and you made it in by the end of the day. Awesome. We're definitely still doing this visit, right? And so hopefully if you can work that into your workflow, that level of flexibility, again, knowing that these visits are only about 10 minutes long, would be super great. But the excused absence policy that you can have on hand for situations where you don't want somebody to have that consequence of a reset in their voucher amount. We've already talked about this. So allows for immovable commitments like surgeries, court dates, and that, going to their niece's graduation might be a really special thing. Maybe they haven't really been included in family events for a long time, and now they're finally invited to show their support, right? So we want to support people communicating to us ahead of time and being able to do things that are, that are good for their lives and their relationships and all those natural rewards that we're hoping are coming back online through them attaining some of the abstinence in the program. So support that, but is also support that communication that you need about it and use it sparingly, because even if they're good reasons, if somebody's, attendance is super spotty, then they're really not going to be able to experience a lot of escalation. They're not going to really see those rewards grow. They're not really going to get that many rewards if they keep missing visits. So really try to find a way to see them twice a week more than giving lots of excused absences. You might have a dropout policy, and that's more just kind of logistics thing that we want people to make a lot of effort to re-engage people, re-engage clients if you haven't seen them for a couple of days. But there might be a reason, and you could maybe be consistent with whatever other discharge policies you have in your, at your setting already. But you might have a policy of how many missed visits in a row before we just say, okay, I'm not going to keep trying to call this person. If they re-engage, then we will welcome them back in. We could restart the program from the beginning. We do want you to continue to track total yearly contingency management dollars earned, because they still can't go over that particular, we'll call it $530 mark, because then that's all that we're approved to be able to give out yearly. And you would want some kind of documentation that they got a new prescription, they have a new need for contingency management. That way you can show that, them restarting in that way. And there's that special consideration that Michelle asked about, COVID-19 related quarantine isolation, absolutely, obviously support public health. So we do want to break into groups soon. Do we want to do a quick run through of a visit checklist, or break into groups? Mike, I'll let you make that call.
I think the plan was to break into groups at 11:30, right?
Okay. Yeah, so we do have a few more
time.
minutes.
I think we may just want to be real efficient, knowing that this is also in the manual, and this is also going to be what we focus in on the coaching calls. So, but yeah, let's go through sort of what a visit would look like would be great.
Okay, and I'm going to hand it over to Rachel for that. So, actually, I'm just going to gloss through this first, opening. We've already emphasized that before that first appointment or at the first appointment, document that there's a medical need. So a stimulant use disorder as part of their treatment plan. If you have inclusion and exclusion criteria, you can establish their start date and, use that client handout consent form. And I've had this question before. Yes, you can go ahead and start them right then and there if you don't have to have like a first, intake and then start the contingency management program. And then you can have a checklist available for just regular day-to-day visits. And that's what Rachel's going to share with you guys.
Thanks, Sarah. So, right. So when you look at these slides, it's good to have them in mind, but I just personally would suggest having this list with you physically. That's helped me so much in doing CM, where it's simple, but there's a lot of details to have to remember. So this is an example of a checklist that you could have out on your desk for CM. So in the beginning, when someone comes in, you could greet them, take attendance, they showed up, and you do that directly through the CM tracking sheet that Sarah just spent a lot of time going through, because it is really important and it's a magical thing to use. And also part of that positive reinforcement is to greet them and thank the client for attending the scheduled appointment. Great to see you today. So glad you're here. Like having that human interaction where you show them that they're appreciated for showing up. And working on their recovery today. It's a big deal. So making a big deal out of that is awesome. And of course, if they're not there, make sure to do no show. Or if they let you know in advance, put an excused absence. So that would be kind of the beginnings of the visit. And remember, we kind of harped on this already. I don't like the word harp. We kind of talked about this already. But when they miss visit 2 or visit 3 or whatever, it is marked as a no-show or excused absence. We don't make up for that visit. So they'll come in for the next visit. So that's always a good point. Next one. And I apologize if I'm talking kind of quickly. We're going to get through this. Obviously, we talked about, greeting them, and then measure is the next one. Sorry, I have my own version here. Right. So this is where we obtain the measure, a very important part of the entire whole CM design. So direct client to the bathroom to provide the urine sample. Check off if you have a physical checklist, and you can check the result of the stimulant urine drug test right on the spot there, and then enter that result into your tracker, and then you figure out if they get rewarded or not. So it's also having this in front of you shows you to make sure that you're really filling out that tracker. That way you get that documented, but also for your own reference. And next one, please. And then so reward, if the stimulant is negative in its result, you get to congratulate the client. Awesome, you did it. Wow, it is negative. Good work, good work on your effort, and kind of share in that excitement with them. and then communicate the vouchers earned today. So obviously you'll refer back to your Excel tracking sheet. If they had some money, if they had some rewards banked, you could talk about that. Ask client if they would like to redeem or bank their vouchers, obviously depending on your setting, if you do the banking methods. And if redeemed, note the total available in the bank, mark the amount redeemed. Sarah demonstrated that for us generously, and go through the next steps for dispersing gift cards. Let's see. So if banked, celebrate today's earning. We really want to emphasize that it's not just like, okay, you're banking it, bye, see you next time. It's like, you did it, like show them what they have in the bank, that positive enforcement, good work. That way they remember that feeling of, I did get something, even if it may not be like a physical gift card on that day, they did earn something positive that day through their efforts of working towards abstinence or achieving abstinence. And then I want to mention in this slide that whatever the dispersing gift cards is, that may look very different, and the exact steps of this checklist will most likely look different depending on the agency and the background, whatever your procedures are. Obviously, if it's a physical gift card disbursement, that's going to look different on your checklist. Open that cabinet. Where's the key for the cabinet where the gift cards are? Fill out some sort of finance log if that's what your agency requires you to do. So there's that flexibility there. You would have to adjust this to whatever fits your agency. And then we can move on to Andre to talk about the next part.
All right, so that's if the results come negative, you get to reward and value that. But you also want to be encouraging when the results are positive, right? So the first thing is not really focusing on the positive result, but especially on the fact that they came and they're telling the truth about their recent use. Sometimes patients will want to tell you and describe what happened, why they're positive, give some kind of excuse. And, it's important to validate there, maybe say something like, it's nice that you're taking something from this labs experience. Hopefully that will help you do better next time. And remind that they only need 2-3 days of absence to be able to test negative in the future, right? And then so you review the reset values and remind them if they achieve those 2 negative urine results in the future 2 sessions, they will be able to go back to that total amount that they had earned, right? That's super important. And then in the cases where a client wants to redeem their money after a positive exam, we need to remind them of what the rules are. And the reasons why we don't allow them to cash out the money is, first of all, we really want to reinforce that desirable behavior of achieving abstinence, right? And if we're giving them $30, $60 gift cards, however how many they have redeemed just after they tested positive, there's a higher chance that we're going to be actually rewarding that less substance use. Plus, the other thing is that there's a higher chance of participants using their gift cards to use drugs if they just got that gift card right after being positive. So it's really important to remind them that the banked value is their value. They're going to be able to access that, but they will need to show demonstrate that they were absent with a negative UA in the future. And then next, and then just to close, it's important to remind them where their next appointment is. So sometimes if you're writing down, if they wanted to bank and you're writing down the total amount, you might include our next visit is next Thursday with the dates. Those are really important, especially methamphetamine users. It's really hard for them to control their agenda. Their time management is not as good. So sometimes having a reminder like that is super positive and helpful as well. And if the participant he's not present, you just check on the calendar for the next appointment and add that to the call list. If you have a case manager that usually does that, it's important that they have that information so they can make the call. And if it's the last visit, you can cash out the total bank voucher. Then again, we were mentioning that if they test positive in the negative, you might have different strategies to deal with them. Maybe ask them to come and submit a negative UA on next week, or even just give them the amount that they earned because they did earn that for being abstinent in the past.
Excellent. Wow. Way to go, team. We hit our time goal spot on. And so thank you all for putting your fast listening ears on so we could get through this material. And I do have in your slide deck that got sent to you, and this is also in the CM manual. There's a few example CM conversations that you can refer to on your own time. Just note with those, so we've worked with a lot of programs that had a lot of different budgets available to them. And so the exact numbers and what the voucher values were in those conversations are a little different than the program you'll be using. And this is a perfect opportunity also for me to, boy, I get to admit some mistakes today. So I'm also going to share with you all, those of you who did the pre-survey and the, about to do the post-survey CM knowledge tests that we sent out. I realized that one of the questions had some specific math in it about escalation, reset, and recovery, and it was based on an older model. So you may find that's a trick question.
It was a trick question.
You
Sarah,
may
you're
find
messaging
that
it
the right
wrong.
answer
It's
is
a
not
trick
one of your
question.
options.
Impossible to answer. It's just impossible to get right. So take your best. It's like the SATs. Get your best guess. So I hope we can fix that on our post test though, before we send it out, which I think we should be able to. So sorry, go ahead.
Yes, yeah, sorry about that, everyone. And so this is where we're going to do some breakout sessions. So we just filled your brains with a lot of information. And now we're going to do a little exercise. We've had some preset breakout rooms that Lindsay will get ready to send you all into in just a minute here. And you're going to do a little exercise called Muddiest Point. And how this works, it's helpful if you can nominate a note taker, or you should have one of us in your breakout room too, and we can help with this. But I want you to think of two separate columns. And I want one column, you can start with this and, but don't spend too much more than 5 minutes on it. But I want you to think, what is the clearest? What is you could teach other people this part of contingency management. You understand it so well. Right? So what are your clearest points? Jot a few of those down, ask your group, and then move on to what are the muddiest points? What is just like, clear as mud to you, right? What is like pea soup fog to you in terms of if you were to do contingency management tomorrow, what do you feel like you would be lost? What you wouldn't be ready tomorrow because you don't quite understand these few points, or you understand them in theory, but how it would actually work where you are is a little bit still a question mark for you. So talk amongst your groups should be very like settings. So that should be helpful to brainstorm these muddy points. And then we'll come back at 11:45 and talk in a group about what those muddiest points were. So I think, Lindsay, can you magically send people to these breakout rooms now? Rejoining the main meeting right now. And I don't think I need to share slides because this part, I can go back and share slides if we ever needed to scooch back to one to kind of illustrate a point. But otherwise, I'm just going to leave it where maybe we can see each other's faces a little bit better now. Then we're going to discuss some of these muddy points. And what we can do, I guess we'll have the group leader from each breakout room sort of summarize some of the things that you talked about. If you elected a group leader that was not one of us presenters, then that person's welcome to talk. Or if I think in my group, I just went ahead and decided I would do it in the interest of time. And so I will go ahead and get started and just let you all know some of the stuff we talked about, and then I'll tag Rachel in to do it next, and then Andre and then Mike. So my group we have a very unique setting that many of the folks, Lindsay, did you need to say something? I see your hand up.
Sorry, I just wanted to point out that Mike's groups is still in their breakout room. So if I am able to close the rooms.
Yeah, why don't you boot them?
Okay.
Thank you. And I'll give it another minute here to.
Yes, it gives them 50. I've got 50 seconds and then it will be.
We've got 50 seconds. Okay, excellent. So they'll be back in a moment. So hopefully, and Rachel and Andre, when you do yours, we could just do, if you had a couple of clear points, you could mention those briefly, but then we'll really get into the muddy points. And even if we don't have a chance to answer all of them, we do only have 11 minutes left. what we can do is at least just kind of all share in the experience of what is still muddy and what might be able to be tackled at these, we're calling them coaching calls. So we're gonna have calls and we're gonna hopefully have similar groups to the groups we had today on those calls. And so we can start really hammering out some of the details. So Mike, since your group just returned, you guys were you're the star students because you were talking longer. But we're just gonna go, me, Rachel, Andre, you, we'll just kind of briefly discuss what you talked about in your room. So I'll start. And I'm going to say that the clear points are that it sounded like everybody really understood that the rewards are based on stimulant abstinence, and they understood that the rewards escalate and then they reset after, after there's a positive test. So all that, the procedures, even, how to use a tracker to do that, all seemed pretty clear to everybody. So that was great. What was muddy is we have a really unique, my group had the unique opportunity in that many of them work in an inpatient setting or in a setting where in a more controlled environment. And so our discussion was often around like, how are they going to either make those referrals into outpatient settings that could offer contingency management? What about the partnerships that they have there? And then would there be an opportunity to initiate contingency management at the end of that inpatient setting and really seamlessly kind of transition to the outpatient? And this is a really great potential, but hammering out some of the details of how that would look like in real life is going to take some thinking. And this is really, really groundbreaking stuff, but could be very beautiful if we can find a way to kind of get the workflow to happen. The other muddy points were billing Medicaid, documenting, especially figuring out the separate chart note and the contingency management tracker. And then what if you do have a lab on site? Right now, they're more accustomed to using on-site labs and not point of care tests. And so that's going to be kind of a hurdle for them. And but that even with an on-site lab, the results are usually not back for another day or so. So let's see what other people had to say, and then we can tackle some of these things. So Rachel, why don't you go next?
So for our group, they were very generous and said that much of the presentation was very clear when it comes to the design procedures and whatnot. So I was very grateful, and I was glad that it was very clear. Some muddiest points were obviously around similar themes of budgeting, about how the budget has increased, and then kind of the details of billing, especially billing for the urine drug testing cups, and the logistics of kind of billing when it has to do with each of these different settings. Budgeting was a big one. And then also another point that was brought up is that one of the people who are in my group is in a low barrier bupe clinic. So kind of logistically providing CM to maybe a certain population in their setting, but not opposed to not another, because some people may struggle with, stimulant use struggles, but the ones who are mostly struggling with the opiate use will not be able to receive CM. So one of the things we're talking about, like, how do we logistically implement this into a system? And I brought this up, like, clients talk, participants talk. So when this comes up within participants, how do we, like, as a clinic, have a unified front on how to explain CM without being like, sorry, you don't get any money, So kind of having a unified front on describing CM to even participants was something that we kind of talked about. And an important muddiest point was, when does this all start for each of these clinics? What are the next steps? When can they start doing all of this? So I let them know. I would bring it up to Mike and Sarah and the group, and I'm sure you'll answer that. So yeah, so that was what we discussed.
Tomorrow. It's great to hear the question about fairness and about we don't want people to just go out and use stimulants to get into the program. That's not what we're looking for, and that's a common question. And so we're definitely going to address that in coaching calls for sure. Mm-hmm. When you're going to start is when you're ready. And so we're going to be meeting with Amy and her team tomorrow to talk about sort of the implementation timeline, and you'll be hearing from Amy and her team for sure.
Okay. Cool. Thanks, Mike. And I'll hand it over to Andre to share.
just unmute here. So I think that one of the clearest thing was the importance of using positive reinforcement and the fact that rewards are associated with the negative urine analysis. Muddiest parts, there were some of them. One regarding the track log, do they need to use it exactly as is? Can they develop a different one? Is it possible to develop a track log instead of by participant and include all of them at one? So that's one question. Another question is, how can they publicize it? What can they say? What can't they say about the intervention? A third question was, how are they going to do that in clinics that are already overwhelmed and understaffed? So that's a challenge. And I think maybe my group can help me. I think there was actually one other question. Oh, regarding the inclusion exclusion criteria to enroll participants in the CM treatment for stimulant use.
Great, Andre. I think that last one, that's another thing, Amy and team, we need to have on the discussion tomorrow is what we're going to sort of decide is the inclusion criteria. In Montana, we're using stimulant use disorder to start with. The other option we've talked about is just as a person used the stimulant in the last 30 days. So, with that, but most people who have used stimulants will probably meet criteria for a stimulant use disorder. So that's a really great question. And then just in the interest of time, I'm going to go on ours. I was leading the jail and then fire department group. And so it was great because we had a number of folks who work at jails and then some of the outpatient providers that partner with them on the call. And then Mandy was able to join us too, which was great because this is really her area of expertise. So the points that were clear, the first, I'm going to share that operant conditioning was one. That was great. The people are learning that. I feel good as a psychologist. And then the second one that was really clear was the what's in it for me thing, which I think is a cool concept for us to all roll with. Because a lot of times we tell our patients or people we work with, you should be interested in this intervention because it's going to be great for you. And they're like, well, what do I get out of it? And then you go through all the side effects of buprenorphine and like, whoa, I don't want that. But here we're going to actually say, here we go, money, it's in it for you. And so I think that's a cool thing to think about in terms of treatments we offer. My take home message, which I know this group cares about because the work you've already been doing is we want to give people a product they want that's desirable. So that was a great. Muddiest points from the sort of jail perspective or capacity, how are we going to do this? We also, talked about how can this program be successful in facilitating that bridge from wanting clarity about how this is going to work from the criminal legal system and jails to the outpatient provider. Do we have some ability to be flexible in terms of how we incentivize that connection or how we make sure that connection is made so that people end up getting to the outpatient provider from jail to get the contingency management? How Tango would actually work and is one. But bandwidth in the jail was, challenging. How people work together in terms of follow-ups, how the criminal legal system and the resources they have could support clients. And one thing that was brought up was maybe, support for some of the social determinants of health, like transportation, which is Sarah, Rachel, and Andre know, and especially for rural communities is a big barrier to contingency management. So I think that was another great muddiest point that was brought up. So these are, again, I'm getting excited, because the real work is going to start when we start our coaching calls and really as you all get started. So I'm excited about that. So Sarah, I don't feel like we have time to solve any of these problems today, but your problems are great because they are really insightful. They're consistent with the concerns that have been expressed in our previous trainings, and they're things we're working on right now. So, and we want to partner with you on. So Sarah, is that a good place?
Excellent. Yes. And because we only have 2 minutes to go, so our team will go ahead and compile these questions just so that we, if we can do a little bit of work ahead of time to be ready for your coaching calls, we can. Some of this is, that billing stuff is going to come from, guidance from the state and not necessarily directly from us, but we can share it with you. And so, so we won't be able to tackle all these questions. I did want to save to the one person, just in case the muddy point is, do you use the tracker all for all your clients or for one client? And the answer is separate tabs for every client. Right now, the way it's designed, I personally can't wrap my head around how you would get everybody on one tracker. So you would want separate tabs for each client. So that's an easy answer. So I can throw that out there now, but the rest we will tackle in coaching calls. And so you will be getting, I think you will be getting an automatic email with a post test that asks you, the questions about contingency management to see, how this training may have helped you understand those points. Again, I apologize that the one that has exact calculations about escalation or reset is using a different reinforcement model, a different schedule in terms of how much the base and bonus vouchers were. So maybe you're just so smart that you were able to do the math based on the numbers that were given to you in that question, but know that they weren't based on the 10 and 2 model. So I apologize for that ahead of time. And otherwise, we look forward to seeing you all. Linda, I can't remember if the coaching calls are already on the books or if people are going to just be looking for an email with their first coaching call that's like somewhere in the future.
Yeah, we have not set them up. I believe we have a meeting tomorrow and I figured we would talk about it at that point so that we can start setting them up.
Yeah, perfect. Right. Thank you, Linda. Because we wanted to be mindful of how we're going to group people in these coaching calls, because it's going to be there'll be smaller groups than this whole training, just so that we can have some really meaningful, get some, each agency or location can get some specific support. So thank you all so much. Thanks for being such engaged learners and for listening to us for 4 hours. And I don't know if we don't have a slide with our email addresses, so I'm just going to put my email address in the chat. And if any,
I think everybody knows that you can feel free to reach out to Linda or to Amy or to Laura or anyone else with questions, and they'll get those to us too. So
yeah, and that works. So go ahead and send the emails that way, and then again we can help prepare for those coaching calls that are coming up. And we expect that it takes a little time to implement, right? So you are going to have to create some policies and procedures at your site that answers some of the questions that are very specific to the work that you do. And so as much as we'd love for you to start tomorrow, it's okay to take some time to think things out and get procedures in place before you dive in. That you'll thank yourself later for doing that. All right. Thank you,
everybody. Take care. Have a great Wednesday. Bye.
Bye.
Thank you. Bye, everybody.
Thanks, everybody.
Thank you.